Yes, Dr. Sunil Kotwal.
Yes.
Please start the meeting.
Good evening. Good evening, everyone. I am Dr. Sunil Kotwal, President IAOHNS. Welcome you all on today's webinar. We are continuing with the webinar series, and today we are going to discuss on the difficult scenario in cholesteatoma surgery. The today webinar moderator will be Dr. Madhuri Mehta. Madhuri Mehta presently is working as a director and head of the department ENT, head and neck, and also she is a medical superintendent at Jindal Institute of Medical Sciences at Hisar. She has also done a fellowship in the lateral skull-based surgery from Italy. She has also successfully performed at least 45,000 major ENT surgeries, and her special area of interest in otology, facial nerve, cochlear implant, and lateral skull base. She has been invited as a guest faculty at various national and international forums. She has also been awarded one of the best serving doctor during COVID times by Economic Times. She has also authored various publications like Atlas of Neurootology of Skull-Based Surgery, Atlas of Ossiculoplasty, and many more. So I now ask Madam Madhuri Mehta to carry on the proceedings and welcome our chief guest and the further proceedings also. Hello.
Good evening. Thank you very much, Dr. Sunil, for your kind words in introduction. And good evening to all my dear friends and colleagues. I feel privileged and honored to be part of this prestigious forum of IAOHNS, which is Indian Association of Otology, Indian Association of Otolaryngology and Head and Neck. So this forum is very prestigious for us, and I have been a member of it since its inception and been part of all its various programs. So today we have a very interesting webinar. It is about difficult and different scenarios in cholesteatoma surgery. For, we have divided this webinar into two segments. First segment consists of a very detailed and beautiful presentation by our chief guest faculty, Dr. Gianluca Spiras from Italy, Piacenza, and he'll be talking about management of Peter's bone cholesteatoma. After that, we'll take up question answers related to that presentation. And then we will shift over to the webinar, this panel discussion on difficult scenarios in cholesteatoma disease and surgery. And that will be moderated by me. And we have very prestigious luminary panelists with us, whom I will introduce when the panel discussion starts. So we will keep certain time for question answers regarding that. Dr. Vijay has promised that he will keep asking us questions asked by the audience in between or after the panel discussion. So I hope it goes well and we are able to give our best to this 2-3 hours of the webinar. So if we can start with the first segment, that is cholesteatoma, management of Peter's bone cholesteatoma. Before that, I will share my screen to introduce our chief guest, which is, let me introduce. Is it visible?
Yes. Can you go slideshow?
So, you know what? I am unable to see the. What happened?
I was very young in that forum.
Okay. Yes. So I'm sharing how to increase the size. I don't know. It has become small sized. How to do that? Just a minute. Give me 1 minute, okay?
Madhuri, we can see everything. Just go on to slideshow.
Okay, that I have, it has become almost in a line. I cannot see it. How to enlarge it, I don't know. You're using that.
Just press the slideshow, we can see everything.
Well, it is so small for me now. I don't know. Is it let me. It is now slideshow. Is it there?
Yes, yes, we can see clearly.
Okay. So talking about our guest faculty, Dr. Gianluca Peras, he is an eminent otorhinolaryngologist and lateral skull-based surgeon, and he has a vast experience for 15 years. He has worked for 10 years in otology group in Gruppo Otologico Piacenza, Italy under Professor Mario Sana. And presently from last 5 years, he's working as a senior consultant in Gruppo Otologico Piacenza only. He was graduated as associate professor by Italian Scientific Board. He has conducted successfully around 1,500 ENT and lateral skull-based surgeries at the same center. And he has numerous publications in his name. He is also part of the editorial board for reviewing different paper publications and books. He himself has published and authored 4 books, which have been published in Chinese language also. And he has been a scientific presenter at various prestigious congresses and conferences all over the world. He is well-known surgeon. He is this luminary personality and surgeon par excellence. We really are happy to have you around, Dr. Peras, and thank you very much for accepting our invitation and joining us. And now I will request you to please start with the presentation on
Thank you.
this management of petrous bone cholesteatoma. Thank you.
Thank you so much for this presentation. I'm so honored to be here with you, as always, with my Indian friend. So for me, it's a real pleasure. Now I will share the presentation. So we can start. Just a second. Okay. Okay. Can you see the presentation?
Yes, we
Can
can.
you see the presentation?
We
Okay, can you hear me well?
Yes,
Okay.
absolutely.
I load the faces in this way. Okay. That's right. Okay, can start. Good afternoon to everybody. This is the. Oh, I can go. Okay. Just which is the incident of this rare disease? Obviously, we are talking about not a classic cholesteatoma of the temporal bone, but a cholesteatoma which involves the petrous part of the temporal bone. So it means that it's an advanced cholesteatoma. It represents about 3% of all the cholesteatomas treated in our institution and nearly 5% of all the skull-based pathologies treated. It's really important to define the name of the disease. Why? Because sometimes there are misnomers that can lead you to problems. The real term, the real terminology in describing this disease is petrous bone cholesteatoma. And I tell you a story about that because once I had to revise a paper from the United States, and the paper was just on medially, it was called medially invasive cholesteatoma. So practically 90% of the literature about the petrous bone cholesteatoma were not considered by the author just because an error in naming the disease. Obviously, this paper was rejected. But anyway, it's really important to call everything as its name. The etiology could be a variable. We can have congenital, acquired, or iatrogenic type of cholesteatomas, as for temporal bone. And from a diagnostic point of view, the first step is the CT scan, which is mandatory, then the MRI, then angina MRI. And also, it has a real important impact right now, the use of DWI sequencing, especially the non-API sequencing. I will explain why at the end of my speech. From the radiological point of view, from a CT scan point of view, it's a cholesteatoma. So it's a soft tissue lesion with a regular erosion, a smooth bony erosion medially to the petrous bone. After MRI, you may have hypointense lesion, hyperintense in T2, hypointense in T1 with no contrast enhancement, as for the cholesteatomas. And the differential diagnosis is between a cholesterol granuloma, which is hyperintense in both sequences, or, for example, in the case of facial nerve tumors, so in case of tumors which involves the petrous bone, the petrous apex, which usually take the contrast. The classification is the Mario-Sana classification, which has been revised in 2000, in the early 2000s, because Professor and our group added some new extension of the cholesteatoma. The original description was in 1991, 1992. But we have a supralabyrinthine cholesteatoma, which is usually centered around the geniculate ganglion, usually is acquired, but could be also congenital. Hearing is usually lost, and the facial paralysis is common because the cholesteatoma is centered in the geniculate ganglion area. We may have infralabyrinthine cholesteatoma, usually centered in the hypotympanic cell, acquired. Hearing can be preserved, and facial paralysis is uncommon. And we could have infralabyrinthine apical cholesteatoma, so that from the infrab compartment it goes towards the carotid artery, or a massive cholesteatoma, so cholesteatoma which involves the whole petrous bone, the whole petrous apex. So we may have hearing loss and also a facial paralysis at various degrees. The apical cholesteatoma is the rarest disease. In all our sample, we have only 2 cases. So it's a real uncommon type. Usually it's congenital, hearing can be preserved, and also the facial nerve may be normal as well. As I told you, we may have some extension into the clivus, into the sphenoid sinus, or into the nasopharynx, or as well intradural extension. These are our sample, and you can see that most of the cases are supralabyrinthine type or massive type of petrous bone cholesteatoma. Which are the surgical approaches? The subtotal petrosectomy has not to be considered so much, except in very small cases. Why? Because if there is a petrous bone cholesteatoma, it means that the otic capsule is involved. So with subtotal petrosectomy, you preserve the otic capsule, so it means that you can preserve the pathology as well. The most important approaches are the transotic approach, which could be combined or not with an infratemporal fossa type B, or eventually a modified transcochlear approach in case the facial nerve is involved. There is not so many room for middle cranial fossa or retrolabyrinthine approaches, except for really particular cases. You see the transotic approach, you practically destroy the labyrinth, you destroy the cochlea, you skeletonize the facial nerve till the geniculate ganglion, and you identify the internal auditory canal. With this approach, you can control the petrous ICA, especially the vertical portion. It's not so important the amount of intradural space that you can control, because petrous bone cholesteatoma usually do not go intradural so frequently. You can have an infratemporal fossa type B. You can have this anterior extension at the expense of the temporomandibular joint. Usually, you cannot reach the middle meningeal artery, but you have to control, in some cases, the anterior portion of the internal carotid artery, because the internal carotid artery, in some cases, has to be controlled 360 degrees. And you can see from this dissection how can the carotid artery be controlled, and also which is the relationship between the carotid artery and the tympanic membrane and the tympanic bone as well. With a modified transcochlear approach, usually you can posteriorly root the facial nerve, or if the facial nerve is massively involved, you can cut the facial nerve as well, and then you can reconstruct the facial nerve, for example, with a sural nerve graft if you have good stumps of the facial nerve. And this is what you can reach intradurally with the transcochlear approach. You can see how can be controlled the prepontine cistern, but it's not the point in treating petrous bone cholesteatoma, the control of prepontine cistern. Which are the surgical issues regarding the management of this disease? Hearing and dura are not so important, so I will be very quick. The hearing has to be destroyed in much of the cases, even for two reasons: because the petrous, the aortic capsule is involved. So if you leave the aortic capsule, it means that you can leave the pathology behind. And second, also the hearing rehabilitation can be optionable. For example, if you have a petrous bone cholesteatoma involving just the posterior labyrinth, so for example the canals, but not if it involves the cochlea, because you may have two problems. One, in controlling the disease, which is much important. For example, with the MRI, if you have a cochlear implant, it would be so hard to control this disease, considering that this disease can recur. Then for the dura, there is no need of opening the dura or cut the dura, except if you have a massive involvement of the posterior fossa dura. That can happen, especially when you have iatrogenic cholesteatoma. But when the middle fossa dura is simply invaded, you can dissect the matrix from the dura and then coagulate the dura. We have the Vasalis, which is a very important tool. Most important is the facial nerve control. The facial nerve could be treated in different ways. Skeletonization means that you can leave the fallopian canal. You can do it with a transotic approach. For example, in a case like this one, if you have an inframalintine apical cholesteatoma with no invasion of the facial nerve of the internal urinary canal, the fallopian canal could be left in place. There is no need to decompress the facial nerve. But sometimes, especially if the cholesteatoma goes in the middle to the geniculate ganglion area, so towards the areas of the labyrinthine portion of the facial nerve and the internal urinary canal, you have to decompress the facial nerve and clean the facial nerve using the cottonoid. That's an example of a supralabyrinthine petrous bone cholesteatoma. You see the extension into the internal urinary canal. It starts with a subtotal petrosectomy. Then you have to remove the labyrinth, you have to remove the cochlea, you have to decompress the middle fossa dura and elevate the middle fossa dura with retractors. Then you can see in the geniculate ganglion area there is sort of a mess, because it's not easy to recognize the pathologic tissue from the facial nerve. Once you have decompressed the dura and you have seen the second portion of the facial nerve till the geniculate ganglion, from the dura to the geniculate ganglion, you can start to dissect the pathology using cottonoids from the dura to the internal urinary canal, and you progressively remove the disease, identify the internal urinary canal both from the labyrinth portion and both from the anterior portion, so drilling the cochlea. Once the internal urinary canal is practically 360 degrees under control, and at the end you can remove the whole disease and coagulating the dura at the end. You see the facial nerve is completely under control. Probably you may have sometimes problem in looking and being sure that all the pathology has been removed from this aspect of the internal urinary canal and the facial nerve, and this is the main point sometimes where you have to decide if to cut or not, or to root or not the facial nerve. But usually with this kind of approach, you can control the facial nerve completely, and then you put periosteum in the internal urinary canal to stop the CSF, periosteum in the eustachian tube, and then fat inside, and that's the post-op. Sometimes you may reroute or graft the facial nerve. That's a case of a petrous bone cholesteatoma. Sorry, extending towards the sphenoid sinus. And in this case, it was a patient from Greece. We had to perform infratemporal fossa type A approach. So we root anteriorly the facial nerve. You see, this is the cholesteatoma from the retrofacial cells. towards the apical compartment, we identify the facial nerve at the level of the parotid gland, and then we reroute anteriorly the facial nerve. This permits you to have, after 6 months to 1 year, a grade 2 sometimes, and 1 is really difficult, but at least 2 or early 3 grade Gauss-Brackmann scale you can achieve. And then you have the space that you need to reach the petrous apex. And now we are drilling the labyrinth. Now we are drilling the cochlea. This is the carotid artery, and all the cochlea is drilled. The facial nerve is this one. You can see the internal auditory meatus, and the facial nerve is this one rerouted, and you have all the space that you need to remove this big disease from all the petrous apex, reach almost the sphenoid sinus area. That's we are close to the mucosa of the sphenoid sinus, and the pathology is removed. You see, this is the facial nerve in the internal auditory canal. Now we are drilling the apical cells of the internal auditory canal. Then you can go with the cottonoid, you can go with the endoscope. I just skip a little bit. You see, this is the carotid artery. That's the critical area. You can see how much pathology there is here. Until you see the healthy mucosa of the sphenoid sinus, you can put a muscle and then fat, and that's it. And that's the post-op. Unfortunately, I don't have MRI. That's another case in labyrinthine apical cholesteatoma. The facial nerve was good, even though the cholesteatoma went into the internal auditory meatus, involving completely the facial nerve. So it started with a transotic approach. So as you saw before, drilling the cochlea, drilling the labyrinth, identify the internal auditory canal, drilling all the retrolabyrinthine retrofacial cells to expose the petrous apex. Now you see the internal auditory canal is completely involved by the disease, and after we had to cut the facial nerve because the facial nerve was massively involved, and all the internal auditory canal was involved. Fortunately, we found a healthy stump of the facial nerve towards the cerebellopontine angle area, and we did a graft between the third portion of the facial nerve in the internal auditory canal in the cerebellopontine angle portion of the facial nerve. These are the scans after time. This is the DWI in 2016. Where you can see also the improvement of the facial nerve of this very nice patient in time from 2013 pre-op till 2016, 3 years. You know that the main results can be achieved after 1 year of your anastomosis, or eventually with other procedure, such as, for example, the masseteric to facial of the hypoglossal to facial. But you can see there is a slight improvement of the movement even after 1 year, and you can see in 2016, 3 years after, the facial nerve is not so bad. So I can see it's early grade 3 facial nerve function, because there are some synkinesis, but anyway, it's good. And you can see from our papers that if you have a good pre-op facial nerve function, it means that probably in the post-op, you may have good post-operative facial nerve function. So from patients with Gauss-Brackmann 1 and 2, nearly 90% of them maintain a good post-op facial nerve function. So you can trust in yourself that the facial nerve can be preserved in most of the cases. Then internal carotid artery. The internal carotid artery is fairly resistant by invasion by petrous bone cholesteatoma. So usually we do not perform arteriography, even though I recommend to do arteriography. Why? Especially in revision cases, and if you are not sure that because there is 2 points regarding the arteriography. One is to assess carotid invasion. Petrous bone cholesteatoma is not like a paraganglioma, so it's not a pathology that involves the adventitia. you can remove the disease from the carotid, being sure that the carotid will have no blowout. But in revision, I will show you why afterwards. Sometimes you may have blowout not due to the pathology, but due to the bone, for example, to the disease, for example, to the because you may have complex cases. So sometimes if you're not sensible, you may have rupture. At the same time, you may have also involvement of the jugular bulb or the sigmoid sinus. So also assess the venous drainage from the brain. You can do with the angio MRI, but sometimes you may need also arteriography to check completely how is the blood flow from the brain. Would be beneficial for your patient if you have to close the sigmoid sinus. So if you have complex case, perform also arteriography to check the whole brain circulation. But honestly, we do not use stent, we do not cholesteatoma. In the carotid artery management, you can drill the tympanic bone to expose the vertical petruzica. You can add an infratemporal fossa type B to also reach the horizontal portion of the carotid. So sometimes you may have this kind of approach needed, also mobilizing the carotid artery and reaching the anterior part. So that's one. That's why I spoke about the arteriography, not because we did in this case, but because there should be complex case like this one. This patient was operated 10 years ago, more than 10 years ago, and it was operated by by the professor of Mario Sanna, so Dr. Zini, and by another neurosurgeon that helped him. And then this patient was lost of the follow-up for more than 10 years. He came to our clinic 2 years back. He did MRI because I start to have some facial palsy right now. And this is the disease. You can see from the fat previously used or almost to the contralateral side. In this case, you should choose which is your most important thing. And in this case was the carotid. You see, now you have to find your landmark. So the temporomandibular joint is shifted completely anteriorly. Now we are looking at the carotid, which is anterior. This is the facial nerve. You can see practically the most important structures are completely inside. This is the labyrinth, completely inside. Like it is floating in the cholesteatoma and in the bone. And also the carotid artery is floating into the cholesteatoma and into the bone. Sometimes, and it happened in some cases, you remove the bone and the carotid blow out. So it's not a question about this can invade the carotid, but is what you find inside. So in a case like this one, you have to be sure that if something happens in the carotid, you don't kill the patient. Then you saw we cut the facial nerve. We also elevate all the tissue on the posterior fossa dura and the granulation tissue. It was not easy to find a correct plane of cleavage between the posterior fossa and all the cholesteatoma and all the granulation tissue. And you see now the carotid is completely decompressed, and we are decompressing we are pushing gently the carotid with the suction, going under the carotid and cleaning all the carotid from the cholesteatoma. It's not an easy task, but if you have knowledge about your anatomical landmarks, everything is possible. In this case, practically, we were able to see also the contralateral carotid. I just skip a little bit the movie. You see, as the previous case, when you reach the mucosa of the sphenoid sinus, you put some muscle, fibrin glue, and then fat inside. You see the carotid here, and all the cavity, middle fossa, posterior fossa, perfectly preserved. And that's the post-op. Then the sigmoid sinus. Well, obviously, you have always to assess angio MRI just to see how is the blood flow from the brain. But this is just a picture of what is happening. It's not a dynamic. It's not a dynamic picture of the real blood flow. So obviously, if you have a case like this one, so you have the cholesteatoma corresponding to the side where there is the only sigmoid sinus or the only and the only transverse sinus, or you don't have any connection at the torcular, you must pay really, really big attention on operating this case, because the risk, if you open the sinus, if you close this sinus, the patient can develop intracranial hypertension. If you can do, if it's feasible, you can also prepare a little bit the neck, the internal jugular vein, and then eventually in emergency you can close the sigmoid sinus and the internal jugular vein at the neck. This is the last step of your disease removal, because the jugular bulb is really, really fragile. So it's better to remove the matrix and coagulate the jugular bulb at the end of your cholesteatoma resection. You see here, sometimes in an emergency, you can open a little bit the internal jugular vein in the neck. Don't do a big incision, because if you have CSF, it will go in the neck. And then you can do extraluminal packing of the sigmoid sinus and then close the internal jugular vein. Then the cerebellopontine angle, I've almost finished. This is another case. It's a real disaster. This patient has been operated, and then she developed anacusis, paralysis, this lower cranial nerve palsy, and so on. So you see a cholesteatoma invading also the intracranial space. So we did a modified transcochlear approach, type B. The facial was not our point, the facial palsy. She had a long-lasting facial palsy. You see the cholesteatoma towards the sphenoid sinus. And then also we had to open the posterior fossa dura in this case, because the cholesteatoma was also inside, so it was like an epidermoid lesion in the cerebellopontine angle. We opened the posterior fossa dura. You see the 6th cranial nerve, and then the cholesteatoma is removed from the pons, and then you see the basilar artery, 6th cranial nerve, pons, perforating arteries, and then the sphenoid sinus is closed, everting the mucosa of the sphenoid, putting a muscle inside, and then fibrin glue, and then the cavity obliterated with abdominal fat, and that's it. And that's the early post-op, and this is 5 years post-op. You see the sphenoid sinus is normal, and then also the MRI, DWI doesn't show any residual disease. So the last point is how to treat with the residual lesion. This is the biggest point to discuss in the future, because we will have a lot of these cases with some residual. What to do? Now 85% of them are asymptomatic. So it's necessary to reoperate them. It's necessary to wait and scan. We have changed a little bit our approach. In the past, we operated all the cases with the residual. Now we are just see if patient is young, we can operate. If the residual disease grows, we can operate. But not all the cases are reoperated. Sometimes the CT scan could be helpful, but usually is much more helpful the MRI, DWI, non-API sequences technique. I won't show this case. Just want to show you that even this case, you see, we use the endoscope at the end to check no matrix under the carotid, perfectly done. And this was the post-op. So the endoscope would help you, but it won't be something that avoids the recurrence of the pathology. Why? This is 2 years post-op. Sorry for the bad images. I've just scanned them. But this is 5 years post-op. You see, residual disease after 5 years. So this is a pathology that should be followed up for at least 10 years. And even after some time, you may have a residual disease. And then we did a revision, and that's 2 years after the revision. So we did an analysis between what we did for example, temporal bone cholesteatomas treated with a subtotal petrosectomy. Obviously, they were not simple cases, but not petrous bone cholesteatoma. We compared them with petrous bone cholesteatomas. Usually also long follow-up, with at least 6 years of mean follow-up. And we saw that the relapse was not so different between a temporal bone cholesteatoma treated with a subtotal petrosectomy and a petrous bone cholesteatoma if done the procedure properly. The only point is that the time for relapse for a temporal bone cholesteatoma, nearly 75% of cases, you may find a relapse in 5 years. While for petrous bone cholesteatoma, you have cases with a residual disease that can be shown even after 13 years. So it means that the petrous bone cholesteatoma has to be followed up even for more than 10 years. There is an inverse proportion between age and growth rate. So in young patients, the residual disease tends to grow faster, even though the mean growth is really small. So if before the 2017, so before the MRI, DWI, non-API area, we try to remove all the residuals. Now we wait and scan much of them, and then obviously if the patient is young and if the residual disease grows, we operate. So I think that we believe that 2 years will be indicated for the second postoperative check and for the subsequent MRI scans if there is no residual disease. This means that if you have this long-lasting follow-up, not all the cases has to be followed up every year. So even 2 years will be enough for your follow-up. So in conclusion, the classification based on radiological work is fundamental in choosing the right approach. The radical removal takes priority than hearing preservation, and a transortic approach is the workhorse for this of this disease. And obviously, more than 10 years of follow-up with DWI, MRI is mandatory. Thank you so much. 3 minutes before half an hour, so I'm perfectly in time.
So it was a marvelous, excellent presentation. I don't have words to explain it. Such clean, crisp. You made all the fundamentals clear in our mind. It was absolutely too much absorbing. We didn't know where the time passed. Thank you very much for enlightening us, Dr. Piras. Thank you very much. Thanks a lot.
You're welcome.
Talk
Thank
about this presentation, Dr. Vijay. So I have one question with you. So in third case, which you showed, the facial nerve grafting was done from the proximal stump and internotory meatus to the part of the this facial nerve. So how do you stabilize it? Whether you applied glue there or applied
I tell you, it's not easy, but usually only if the anastomosis is with the extratemporal portion of the facial nerve. That's not the case. We use stitches. Otherwise, we take a piece of temporalis fascia, and then we practically we use the temporalis fascia as the content of the anastomosis, and we glue it. In this way, the stumps are secured inside the temporalis fascia and glued.
Okay, and so you wrap it around the fascia.
Sorry. Yeah, we use the fascia, and then we try to use a quite long sural nerve, just to avoid that also the weight of the fat will, in a way, disrupt the anastomosis.
So you do the static procedure on facial nerve, like upper eyelid lid loading with fat, or you're using fat or gold implant or platinum implant?
Well, in case you do the anastomosis with the sural nerve, what we do before discharging the patient, we do lateral tarsorrhaphy, because the patient can improve the facial nerve function even without doing other procedures. Only if we do a static procedure. So, for example, after 3 months, we do a masseteric to facial nerve anastomosis. Then after 6 months to 1 year, we proceed with the weight. But we usually wait before putting anything in the eyelid. We just wait at least 8-9 months. Before doing that, we do tarsorrhaphy, because you may have also an improvement of the upper part, and so maybe you don't need to put other issues inside the eyelid, even because in Italy you have to pay for them, so it's really expensive.
I know, but
everywhere is like this.
Yes. In our practice, we do it immediately in 1 or 2nd stage, so that because when you're putting a graft, it will take at least 9 months, 1 year to 2 years
for
the improvement to come. So eye closure can be achieved, but it was excellent. I think Dr. Vijay, do we have other questions for him, or shall we move over to the panel discussion?
Yeah, you can move on to panel discussion. And there are a couple of questions I have posted in the group. If anything relevant to this discussion, you can talk.
Okay, so shall I take up those questions or in the end only?
No, you can take it now itself, please.
Oh, I'm trying to see where is the chat box. It's not showing chat box.
The question is from Dr. Mohan, that is this lateral based approach is adequate enough to completely disease clearance with preservation of neurovascular bundle? So that's the question from him. Can you hear?
Dr. Piras?
Sorry? Yeah, sorry. I'm looking at the chat. So are you talking about the questions in the chat?
Yeah.
Yes.
So
Ah,
Dr.
okay.
Mohan,
Well, is that adequate to put this with preservation? Yes. Absolutely. The first question, the lateral skull base approach, the point is that the first question, you do not have to follow the disease. You follow the disease at the end. First, you do the approach. So if you do a transotic or if you do a transotic with infratemporal fossa, you stress yourself with the approach. So looking at the anatomical structures, the middle fossa has to be decompressed, the sigmoid sinus, the posterior fossa, the facial nerve, and then you go towards the disease. In this way, that's the best way to preserve the neurovascular structures, especially the facial nerve. Otherwise, if you just go towards the disease, as for example, many endoscopic surgeons are trying to stress, the risk is that you go directly inside the structures and you may do damages, and you do damages without removing the pathology. So that's a big point. So the lateral skull base approaches, if properly performed, are adequate. The second question is, you don't have to pack the external auditory canal, because your external auditory canal is transected at the beginning, and you close the external auditory canal as a cul-de-sac. So you do an external layer with the skin and an internal layer with the cartilage and the fibrous tissue of the concha. So practically you have two layers, and the external auditory canal is completely secured and outside your surgical field. So you won't have any granulation. Even if you will have granulation afterwards, even if you perform this very good closure, sometimes if you have the second layer inside, the external auditory canal closure won't open again. So even if you have some granulation, you can put hydrogen peroxide, you can put some drops, and it's enough. Afterwards, you will have complete skin, healthy skin on your closure. In practical, you won't see the closure after months.
So, thank you. Maybe we will keep on getting certain more. If somebody is asking, Dr. Anu from Delhi, is the Peter's cholesteatoma same as congenital cholesteatoma?
Well, sometimes you may have some Petrus bone cholesteatoma misdiagnosed that can develop from a congenital cholesteatoma. So you may have the same disease, but usually the Petrus bone, it's nearly iatrogenic or acquired, not properly treated cholesteatoma as the first stage. But you may have cases that originates as a congenital one.
Okay, thank you very much.
You're welcome. Thank you. Thank you.
We'll move on to our second part, which is the panel discussion. So I'll be sharing my screen. That will be like, you will also be a part of the panel, Dr. Piras. So let me introduce others also. So the topic for panel discussion is management of difficult scenarios in cholesteatoma disease. And I, as moderator, I'm being the moderator. The panelists are you, Dr. Piras. We have already introduced you. So rest three are Dr. Anjan Buyan from Kolkata, Dr. Narayan Jaishankar from Mumbai, and Dr. Monish Grover from Jaipur. So before I introduce you further, cholesteatoma to me is not a disease. To me, it has always looked like an enigma to be understood, to be decoded, so that we can manage it well. And managing cholesteatoma is not a surgical procedure. It is a big project, as you have shown us today in the Peter's bone cholesteatoma. In the same way, it erodes and eats up the temporal bone in a way and goes to different crevices that we have to be very thorough in our complete removal. It starts at the very first visit of the patient to surgeon and ends with a non-doctor dependent one well-functioning ear for the patient for rest of the life. So talking about our panelist, I have already introduced Dr. Piras. The next is Dr. Narayan Jaishankar. He is a dear friend of mine and a surgeon par excellence. He is methodical, disciplined, and a well-known star surgeon in our country. He is known for his work on otology, neurotology, lateral skull-based surgery, PNS, endoscopic transnasal skull-based surgery, and facial nerve surgeries. He has been invited to over 250 workshops in India and abroad as faculty. He has published peer-reviewed papers in high impact factor national and international index journal. He is a reviewer for various index journals as well. He has contributed chapters to various textbooks and has authored two very good atlases, Atlas of Neurotology and Lateral Skull-Based Surgery and Atlas of 360-degree Skull-Based Surgery, both by Theme publication. Coming to our next panelist, Dr. Anjan Jyoti Bhuan. This is something I must proudly say that Northeast, the most beautiful part of our country, was not represented by many in the past. Now they are really evolving and that part has started shining. And Dr. Anjan has taken this, he can be credited because he's doing great work. And he's also a surgeon well known in the country. He's founder of the Northeast ENT Institute, a prominent ENT clinic in Guwahati. He's currently working as an associate professor in PIMC Meghalaya, and his area of interest mostly lie in microscopic ear surgeries, vestibular pathologies, and endoscopic skull-based surgeries. The last but not the least, Dr. Monish Grover. Who doesn't know him? He is the rising star in our country for otorhinolaryngology and skull base and for cochlear implant work. He is the professor ENT and additional superintendent SMS Medical College and Hospital, Jaipur. He is the secretary for Cochlear Implant Group of India and more than 100 publications and textbook on cochlear radiology and cochlear implant to his name. So we will start this thing without wasting time. So gear up all the panelists. We will try to pass on the question to each of us, each of you all. So please try to add on to things rather than repeating because it is a long topic and it was really, really difficult for me to take all the questions together. So what are the aims of cholesteatoma surgery? Before we go ahead, we all know we have to make ear safe and dry. And second is maintain or improve the hearing level. I have crossed the maintain part because I believe, rather we believe in improving or restoring the hearing loss if it is conductive hearing. We avoid dizziness postoperatively. That means that we maintain the sanctity of internal ear properly and the surrounding structures. We avoid cavity formation because cavity formation doesn't make the patient total non-dependent of doctor. He always has to keep coming to the doctor for cavity cleaning. So we believe in cavity-less or small cavity cholesteatoma surgery. And the most important thing is very less people talk about it. We'll talk about it. Wide enough metoplasty to avoid the possibility of disfigured meatal opening leading to cosmetic deformity. Patient ear should be non-doctor dependent with restored or improved hearing for the rest of his life. And Dr. Piras, I learned that you are having almost 18% residual or recurrence of cholesteatoma in temporal bone cholesteatoma cases. In our country, because it is so much volume of cholesteatoma, people learn it very fast and they have different ways of doing it. And we have almost reached less than almost 2% residual or recurrence. And that is what we are going to share today. So our questions, first is basic concept of cholesteatoma disease and its management. Can I ask Dr. Narayan to elaborate on this? There are 3 points I have taken. Inside out versus outside in, canal wall up versus canal wall down, microscope versus endoscope. So Dr. Narayan, can you talk about inside out versus outside in?
Okay, hi everyone. So we'll keep this very precise. Inside out versus outside in is really not a concept which we would like to discuss. These are two different ways of achieving the same objective. Okay, today the concept is all about whether you would want to keep the canal wall up or take the canal wall down. The technique of inside out versus outside in, like I tell my juniors, let's debate on this if just a minute. Okay, when we do an inside out, we are talking of three basic procedures. Okay, just to keep, in spite of all the volume of the terminology that we have, I try to keep it simple. When we have a cholesteatoma which is limited to the attic, okay, then we are doing an inside out atticotomy, but reconstruction of the lateral attic wall, maybe with cartilage. If we have it going from the attic to the additus, it's called an atticoantrostomy with a reconstruction of the lateral attic wall. And if it's going into the mastoid completely, we talk of a canal wall down technique. In outside in, the same things which are achieved in outside in technique, when you have a cholesteatoma limited to the attic, you would probably want to do a cortical with an epitympanotomy and then try to remove the disease. The only problem in these techniques is you need to make sure that the lateral attic wall is drilled. And that's the reason why, that used to be the reason why in canal wall up, they used to talk of a second stage look-in procedure. Whereas if you do what we call the lateral IBM technique, then there is a less chance of leaving behind the disease. And again, you can reconstruct the remnant lateral attic wall with cartilage. So we are talking of a lateral IBM technique, or then we again take the whole canal wall down. So inside out or outside in basically tries to achieve the same objective depending upon the extent of the cholesteatoma. The only thing is, in outside in technique, when we do it, we retain the lateral half, like I told you, of the lateral IBM. So it's easier to reconstruct the medial half of the lateral attic wall. Whereas in the inside out procedure, you're actually destroying the whole wall right from superior or the most lateral aspect right down to over the incus, the whole lateral attic wall. You're keeping on following the disease from inside out. In good hands, both these procedures have equally good results. I have been managing inside out and outside in both, but this is something which I think demands not much discussion. I just spoke this only because there are a lot of juniors who always talk about this. The concept is always canal wall up or canal wall down. Okay, so again, that's the second point. When
So your point is that exposure of the disease is important.
Yes, exposure of the disease. And in canal wall up, the problem, like I told you already, was retention of disease in the lateral attic wall. That's the space, say Prusak space, somewhere between the incus and the lateral attic wall. So if you leave the canal wall intact, that was the area where people used to leave behind disease and have a second look operation, and there was an increased incidence of recurrence. People then used to go and do a second surgery for that. We in India do everything in just one single sitting. So what I do is I don't retain that canal wall intact. If I really want to retain, I'll retain it like an intact bridge technique, the lateral half of the canal wall, whereas the medial half, I'll make sure the cholesteatoma is completely out and then reconstruct the same. Microscope versus endoscope is again a debate. I know endoscopy is booming, just as it boomed for the endoscopic ear surgery. I've been fascinated to see the amount of work that has been done with an endoscope for cholesteatoma. Personally speaking, I think I like microscope because you have a two-handed technique. That's why when people use an endoscope, I've had this debate with people like Marshoni and Insyok Moon, etc. They use microscope most of the times. The difference is if you're using an endoscope, like say Mubarak Khan is doing in India, you use a microscope holder and then you use two hands. It's very difficult to keep an endoscope in one hand, drill and then irrigate and suction. I don't find that a very useful thing. Endoscope helps you to look into the crevices, and that's a good thing. That helps you to get a more distal illumination. All that is fine. For drilling though, I think it's better to do it with the microscope.
Scopes for difficult and hidden areas, as he was showing us in the Peter's bone cholesteatoma. Rest you believe in microscope. So, okay, Dr. Piraz, do you have anything else to talk about it in your part of country? How do you go about it?
Yes, well, I will be very schematic. The problem is what to do. Well, what you saw regarding our rate of recurrence, so 18%, was not the rate of recurrence in cholesteatoma surgery, but the rate of residual disease in complex cholesteatomas after a subtotal petrosectomy. The problem is that nowadays, talking about canal wall up and canal wall down, it's something not up to date. Why? Because we know that after a canal wall up, nearly 30% of cases will recur, will have a residual of a recurrent disease, which means that after time, you will have a new retraction pocket that could develop into cholesteatoma. And it will be like this, even if you reconstruct the attic, put a cartilage, reconstruct the posterior canal wall, you will have a recurrence. 30% of cases. I published a paper regarding the management of pediatric cholesteatoma, when it's clearly written that if you follow the cholesteatomas from 40 years for a median of 4 years, you will have at least 30-35% of problems in your closed tympanoplasty. So that's the reason why after the 90s, in our group, we have shifted into canal wall down in nearly all the cases, except two situations. If you have a really pneumatized mastoid, so that's the case, you have a really pneumatized mastoid which could not be easily managed, or if you have a congenital cholesteatoma, because the pathophysiology is completely different from an acquired cholesteatoma. And that's the second point. So you have also to stress not on the technique, but on the pathophysiology of the disease. If you have a retraction pocket, a big retraction pocket on the attic, it means that the eustachian tube doesn't work. So it means that your cavity in time will not be the same of what you see in the first 2-3 years. So that's the other reason why we prefer the canal wall down. And then inside out or outside in, it depends just on the mastoid. So if you have a contracted mastoid, you start with the inside out, except starting from the mastoid to the attic, but at the end you reach the final point of a canal wall down tympanoplasty. And if you use this kind of philosophy, the use of the endoscope, yes, can be helpful in some cases if you have a deep mesotympanic area. But if you do perfectly the technique, you don't need any endoscope to remove the cholesteatoma. Okay. Now we are looking a lot of cavities where the endoscope is used, because Italy is the country of the endoscope. We see a lot of cases where when we have to revise. Why? Because they do the same principle of a canal wall up. So you do a small atticotomy, you go with the piezo surgery, you go with the endoscope to remove the skin, and after a while you have or a cholesteatoma inside your cartilage, or eventually you have a retraction that develops into a cholesteatoma, so you have to do a canal wall down. So it's the same problem. So technology cannot substitute your surgical technique.
Okay, thank you. Dr. Anjan?
Yes.
Hello. What you say about very restricted, limited retraction pocket? It is involving only partial attic. So what is your say about going for, limited removal of disease and reconstruction of canal wall or canal wall down?
Yes, ma'am. So what you are asking about the basic concept of cholesteatoma disease, it's only a surgical management. So whenever I do a cholesteatoma surgery, always I start with the elevation of the postmetal skin, and as I see inside, it's whether it is a limited or it's extensive, whatever it be. If the IS joint is intact, then my approach is little different, and if the IS joint is eroded, then my approach is little different. Whatever it be, I am very much cautious if the IS joint is intact. If I try to look into, I try to do a little bit of atticotomy in a limited diseases, and with atticotomy, if I can see the disease extension, what is the, if it's possible, if I can remove the disease without very limited disease, what you are talking about, the retraction pocket and all. If the with intact ossicles, if I can remove the disease in toto, so I will remove the disease and do it accordingly. And most of the situation, what I do, I dislocate the joint and remove the ossicles, do the atticotomy and check. if the disease is removable in the attic itself, then I will remove the attic and remove the disease. And if it is going behind, most of the time
when you are doing the epicotomy, you do the reconstruction also, posterior superior canal.
yeah, definitely, ma'am, definitely. Whenever I do the epicotomy, I reconstruct the attic wall, and I follow the disease posteriorly. If it is the disease is going posteriorly, and sometimes if I think like it's going more posteriorly, I go from the mastoid. I open the mastoid and see do a epitympanotomy and check the disease. And if needed, then according to the level of the disease, there I remove the I lower the facial bridge.
Okay.
So my lowering of the facial bridge canal down will depend on the extent of the disease only. Not
We will come further
have,
as those steps. We have many questions. We will talk about it further. So now we come to most important steps of surgery, which make the cholesteatoma surgery. Before that, I have just drawn a diagram for everyone to see. There are 4 important parts. Now this is canal, medullary, mastoid. Canal is divided into cartilaginous and bony extraordinary canal. This is medullary and attic. This is mastoid air cells. So important steps. If the disease is here, and this is narrow entry, and we may even need to remove all these cells to go there. How we go about it? So these are the important steps. I'll ask one by one to each of you. So canalplasty, canal wall up or canal wall down, mastoidectomy, ossiculoplasty, after removal of the disease, ossicles are reconstructed. Then we do either reconstruction of posterior canal wall or obliteration of cavity, and last is meatoplasty. So these 5 important steps make the steps of cholesteatoma surgery. So when coming to canalplasty. So canalplasty is basically widening of bony external canal from lateral to medial side towards annulus. And it has got 2 parts, canalplasty. One is when we drill the bone in the canal till the tympanic membrane annulus is visible in whole circumference. And second is very important for the cholesteatoma surgery, when we remove the bone anterior to the vertical course of fallopian canal so as to open up the whole sinus tympani area and remove the disease, because this is one of the area where there is, or we tend to leave behind the cholesteatoma. So my first question is to Dr. Piras. Do you believe in doing canalplasty before going ahead and doing the performing the further surgical steps in cholesteatoma surgery?
Madhuri, you pointed a really, really important step. I perfectly agree with you. This is one of the most important things in not only in cholesteatoma, but in middle ear surgery in general, canalplasty.
Okay.
So I completely agree with you.
Oh, thank you. So Narayan, do you have anything else to tell about it?
No, I think it's perfect because you need to do a canalplasty. You need to identify your annulus completely in its periphery. Even when you're doing a surgery, you need to identify the annulus in the periphery, and you need to see your sinus tympani area clear. So you do require a bony meatoplasty in all cases.
Almost all cases, yes. So next is canalplasty, like what Dr. Piras was saying. If it is a restricted disease, Dr. Piras, so if it is involving attic, if we restrict ourselves and remove the disease in a restricted way, go beyond the extent of cholesteatoma, remove it and do the reconstruction with cartilage or bone. So you obviously have told us that you don't believe in that. Even
No. I'm sorry. I won't say I don't believe in that in 100% of cases. We had some case. We had a lot of cases, especially in children, when this is the first surgery. So we do this. But I also have to tell you which is the other side of the story. So nearly 30% of them then will be converted into a canal wall down after years. So, but if we can, we try at the beginning to do like this.
Okay. So, Dr. Anjan?
Ma'am,
Yes.
I like to add one point in canaloplasty, because most of the juniors, they just fear of doing canaloplasty, that whether the facial may come in while you are drilling. So it's very safe usually. It's a minimum 3 millimeter, and sometimes in the lower part 4 millimeter also we can drill.
Almost
So,
5 millimeters behind the anterior margin of the fallopian canal. is 4
Yes,
to
yes,
5
ma'am.
millimeter posterior to the
Yeah.
anterior margin of the canal.
Yeah, yeah. So
This
3
much,
to 4 millimeters safely can be drilled out.
yes, yes, absolutely. So,
Yes, yes.
you know, restricted disease, we tend to do posterior canal wall reconstruction. Actually, canalplasty and myotoplasty both are the procedures performed on the canal wall only. This is to widen the bone, this is to widen the cartilaginous entry. So maybe canal wall up mastoidectomy, we just need to do canalplasty, remove the disease and reconstruct. Whereas in canal wall down mastoidectomy, as Dr. Piras was talking, so what if we go ahead, just remove the disease and clear all the cells, it will be narrow entry and wide cavity. So come the role of canalplasty, removal of the disease, obliteration, and then myotoplasty. So we will talk about the just one video to show how we go ahead and do the removal of limited disease of cholesteatoma. We remove the lateral wall of the attic and antrum, reach the outermost extent of the cholesteatoma. We never try to break the cholesteatoma or integrity of it before we go around in all directions in its outermost extent and then remove in toto towards the middle ear. So that is how it is a very beautiful disease that it creates plane for itself. So if we are gently peeling it off the underlying structures, we can very safely remove all of the disease in one go. So this is how the lateral wall of the attic is removed, whole disease exposed and removed in toto towards middle ear. And if we feel that the patency of the mastoid is not visible, patency is not sure, then we can do even cortical mastoidectomy from behind to achieve the patency of the
Clear.
mastoid. So, but we have now removed the lateral wall of the attic. So what are the grafts you use for reconstructing the posterior superior canal wall? Dr. Piras, what are your options for using the cartilage graft to reconstruct the posterior? Are you doing it frequently?
We usually, when we reconstruct the posterior superior canal wall, as in this case, we use cartilage and then we collect some bone paste from the cortical mastoidectomy to put together with the cartilage.
Make it stable.
We do not use heterologous material, just cartilage and bone paste.
Okay, so Dr. Narayan, do you use any bone also, posterior canal wall bone, or any other material to reconstruct it?
No, I think we always reconstruct with cartilage and make sure that this, the cartilage is placed very well. The problems come when the cartilage gets displaced, and that's where your epithelium starts growing haywire. You need to make sure your lateral attic wall is properly reconstructed. And when you place your graft should go over the whole reconstruction assembly. So you're actually directing the epithelium where exactly it needs to grow. So that's what I would say, cartilage.
So what you do is, you drill the grooves on both the sides, and as Dr. Piras is telling, that use the bone dust to keep it in place. So few more important things, if you can, Narayan, comment about it. What to take care when we place this cartilage to maintain the patency, and when we do a ossiculoplasty, what to, few important tips.
Okay. So first and foremost, you must remember that eustachian tube function, as Gianluca already said, we are not able to assess poor or good eustachian tube function in many of these cases, right? They could have a bad eustachian tube. Either which ways, when you do a reconstruction over here, you have to take care of cartilage. I generally keep cartilage with perichondrium on both sides. If you devascularize, if you take out the perichondrium, at least there should be perichondrium on one side, if not both sides. But if you take off the perichondrium completely, I do not think that cartilage is very viable. It could probably crack up and even dissolve. So you normally leave it with perichondrium. Like Madhuri, you have already said, you put grooves on either side and reconstruct this. Now, whenever you're talking of reconstruction, you're trying to reconstruct the normal anatomy of the ear. So if you reconstruct the ossicular assembly, you're trying to reconstruct the ossicular assembly almost nearly the same way as it was earlier. Whatever is your method of
as normal as possible.
Exactly. And same with the cartilage that is placed for the reconstruction of the wall, you place exactly in the amount of bone that you have removed. You don't try to place it too deep down or too deep over the fallopian canal. If it goes that way, then it's going to completely obliterate your ventilation pathway and cause you a lot of trouble. So you need to maintain that ventilation.
Medial to it for the patency to keep.
Yes. So you have to have at least a ballpoint probe which you can pass from the middle ear going into the, say, mastoid region to make sure that ventilation pathway lateral to your ossicle is still maintained. And I think you would stabilize this cartilage. If it's too large a cartilage, it will buckle. If you could stabilize it well, it remains steady. It doesn't get displaced. If it gets displaced, then you're in trouble again.
Yes, absolutely. So few cases we have been using the posterior canal wall. We thin it and create a curved graft out of it and can reduce the size of the external canal by placing the bone as well. So these are some post-surgery. So if you do it nicely, so things happen very beautifully. This is incus, this is posterior canal wall reconstruction. You can even see the movement of the incus also. And if we use some cartilage as a strip over the head of stapes and the annulus, so you can see the reconstruction very nicely. Coming to this canal wall down, this was canal wall up. Now, Dr. Anjan, this is for you. What extra steps? If you have done canal wall up, that means it for restricted disease, you removed and reconstructed the canal wall, and we maintained the middle ear cells with mucosa intact because they will participate in the ventilation of the middle ear and mastoid. So for canal wall down mastoidectomy, what different steps you plan other than the canal wall up?
Okay. So when we do canal wall down, that the down means the complete down of the canal wall. Means we'll have to lower the facial bridge up to the level of the mastoid tip or to the at the level of the canal, so that there is no cavity or nothing remains. If there is a little bit of pocket and all, then after extension of the disease, we'll have to fill those pockets with the periosteum or cartilage or other materials, whatever be. But there should not be any dependent areas.
Hidden areas.
So no dependent areas after doing a canal wall down procedure. So if possible, we'll try to obliterate the cavity as much as possible. And for the reconstruction part,
we will come to obliteration next.
Later.
Presently, what extra steps you can think of? Lowering the facial ridge, thinning the facial ridge, saucerization.
Yeah. While lowering the facial ridge, we see the level of the lateral canal and till the level of the inferior medial wall. So we'll have to say with a diamond drill and be little bit bigger with a lot of irrigation. And during that procedure, we need to look into the sinus tympani area, facial recess area, need to check the facial.
Yes. That is the next question we are going to talk about. Okay, so next question will take all those areas. So, Dr. Piras, what is your suggestion to the audience when you're close to the facial nerve or important structures? Few important tips and pearls regarding usage of burr or other pottery and etc. What do you have to say?
In canal wall down, as you are showing in this beautiful picture, what is important is to see the level of the middle fossa, the sigmoid sinus, and then do a proper canalplasty. After that, you lower the facial ridge, and the points that you have to see perfectly to avoid any damage, for example, on the facial nerve is the second portion of the facial nerve first. And usually in canal wall down, you remove immediately the incus, so you can see very well. And then also the pyramidal eminence and the stapedial tendon, which gives you practically the depth or your gene of the facial nerve. These are just few tips, but anyway, if you start with a proper mastoidectomy at the beginning, then the deification and the lowering of the facial nerve is straightforward. I think that there is not much to add on what you have already said. You said everything about that.
Narayan, do you have anything else to tell about what?
Yeah, I think for the junior audience, we need to make certain points very clear. Okay, when we are seeing a good cavity over here, the areas which you need to clear, okay, you can see Madhuri's picture. Madhuri, I can't obviously move an arrow, but you can see her middle fossa plate, all the cells are excentrated. It's very important to clear your sinodural angle. That's the area where people generally hesitate to clear that area and then to leave behind cells or residual cholesteatoma in that area. Similarly, mastoid tip area is one area which you really need to take care of. People just generally do a cavity work and leave the mastoid tip. So the mastoid cells need to be excentrated completely. And if the mastoid is too deep or too much, going down below the level of the middle ear, that's the lower aspect of the middle ear, below the hypotympanum, then you would probably even excise the mastoid tip. Okay.
Yes.
You need to also go to the anterior epitympanum. Madhuri, if you can just put an arrow over there, the area you earlier showed it being drilled. Okay. That's the area of the anterior epitympanum. The anterior canal wall must be flush with the anterior wall of the mastoid cavity. Okay, it must be very, very smooth and there must be no hidden areas because that's the area again you leave behind cholesteatoma. Your canal must be lowered down almost till the level where you can see the facial nerve with under the bone. And you must also drill the area of the sinus tympana area, excentrate or clear that area completely to excentrate the disease completely. So these are the areas where I think you need to take special emphasis and try to excentrate the cells completely. Now the cells may go in the retrofacial area. Madhuri, if you could point the retrofacial area or say the infralabyrinthine area cells. Yeah, those cells over there, those cells sometimes go deeper than the labyrinthine canal. It may not appear as smooth as Madhuri's picture is showing. You chase those cells even after the cholesteatoma is removed. So there is drilling to expose the cholesteatoma. You take off the cholesteatoma and there's drilling below the cholesteatoma to excentrate all these cells and try to make the mastoid cavity almost a white, well saucerized cavity.
So, okay, all these points well taken. One more important thing, saucerizing, milky white and lowering facial region. This anterior, this is epitympanic area because now we will be obliterating this mastoid portion. So the ventilation pathway, transmucosal gas exchange has to happen in the middle ear along with the eustachian tube. So we tend to leave the mucosa of epitympanum to keep working for this transmucosal gas exchange. This is very important. We maintain the mucosa, rest all mucosa and cells are taken out. Okay. So now coming to important tips to achieve complete clearance of cholesteatoma in extensive or difficult scenario. So sinodural angle, these are the areas what we have been talking. The cholesteatoma may be draped over semicircular canal fistula. It may be draped over dehiscent facial nerve. And there can be a facial nerve neuroma. It can be draped over foot plate and anterioretic area remains hidden. Then sinus tympani and hypotympanum, and it may be draped over exposed sinus and tegment. So one by one we will take up. So you can tell Dr. Anjan what special thing to keep in mind when you are looking for sinodural angle. How to make sure that you have opened it up and excentrated the disease.
Yes, before starting the surgery, when you look into the CT scan, you need to seek the length or the depth of the sinodural angle, left of the sinus tympani. We are talking about the sinus tympani, no, ma'am?
Yes. No, first we are talking about sinodural angle. When you do surgery, how you locate it? Many times it is hidden in disease. And
okay. So for that, we'll have to trace the tegment tympani. We exaggerate the cells on the superior tympanum and follow the sigmoid sinus wall, and the angle between these two will be the sinodural angle. So that we need to clear up. And
so we must make sure that we have opened it up and excentrated all the cells.
Yeah, tegment and
Doctor, last time this next question is to you. If we are suspecting any fistula there, and when we are lifting the cholesteatoma sac, peeling off, what care shall we be taking when we are suspecting a fistula down?
Well, from the CT scan, but sometimes you may have old CT scans, so maybe you operate the patient and you find a fistula by chance. The most important thing is that not use the aspiration, the suction on it. So you can gently peel the matrix. It also depends how wide is the fistula. If the fistula is really big, it could be a problem. But if the fistula, like here, is can be controlled, you just peel with the plaster dissector the matrix without using the suction on it, and then immediately after removal of the matrix, you can put a piece of fascia, a piece of fibrous tissue over it, trying to preserve the membranous labyrinth.
That it, an island of cholesteatoma sac or epithelium can be left there intact on the fistula. And
Well, if you know pre-op that the fistula is pre-op that the fistula is quite big, you can leave the cholesteatoma over it, you can leave the matrix over it, and then control the patient. Usually, when the cavity tends to be reepithelialized, you may have corresponding to the fistula eventually a small piece of cholesteatoma that you can remove eventually with the microscope also in the office, maybe a pearl of cholesteatoma. But usually we maintain, if the fistula is big, the matrix over it, because the risk of losing the hearing is so high.
Okay, Dr. Ras, do you do something for the decongestion? Use some adrenaline-soaked cotton balls or gel form to make the area decongestion and identify it?
No. Sometimes I use when I have to dissect and the dissection is really delicate. In a case like this, I use a syringe with a small needle and with some saline water with physiologic solution, and I use the irrigation and I use the water dissection, but not mesna or other drugs.
Okay. Dr. Narayan, next. Hello.
Yeah, go on. Yeah, Madhavi.
And now the fistula is over. If we are suspecting a dehiscent or it is a iatrogenic injury.
Madhavi, can I make a small point on the fistula thing?
Why not?
Yeah, we have not discussed how we would deal with closing this, because
It will come. It is there.
All right. Go on. Then go on to the next question. No problem.
It's just the earlier steps. We will talk about per situation. So if we are suspecting a dehiscent facial nerve or a iatrogenic injury already has been depicted in the CT scan, or the patient is having facial palsy, and when we are suspecting a facial dehiscence, what extra care you take when you are lifting the cholesteatoma sac from it? And second important question is how you approach the facial nerve, because you can come from posteriorly, anteriorly, inferiorly, because we don't want to injure, we want a plane to be created. So how you go about? What is your practice?
Okay, so if we see a dehiscent facial nerve, we already know about this in the pre-op scans. If it's a revision case or a primary case, if there is a dehiscence and if the the same way as we would do in a primary case, I would not take any special precaution. I would not use adrenaline balls, etc. I would use the backside of my sickle and create a plane between the cholesteatoma matrix and the facial nerve and dissect it off the facial nerve, taking off the complete matrix, preserving the facial nerve under it. So dehiscent facial nerve, you just need to be careful not to injure it with your instruments, causing an iatrogenic injury, unless there's an injury already done. If there is an injury already done in sort of a prior surgery, you need to be careful. And
fibrosis already settled in, then what do you
do?
I mean, it is a case of post-iatrogenic facial injury with fibrosis around it. It is a clean, the picture I am showing is very clean. You know, there is a dehiscent facial nerve, but many times there can be a lot of fibrosis there. How you find your way through it? That is the most
exactly. You try to find some normal area of the facial nerve. It's a completely game of anatomy. You find some area where there is a vertical course. For example, if your tympanic segment over here is damaged, you would trace the nerve on either side and then try to find a plane between the normal nerve and the fibrous tissue or the cholesteatoma itself, and then go about dissecting the cholesteatoma.
The important point what you pointed out is you look for the normal facial nerve around and then try to find the plane between the injured and the this part, because that will guide us towards the right plane. So good. So now, Dr. Anjit. Hello. Dr.
Yes,
Anjan?
in dehiscence facial nerve, it is yes, ma'am. Can you hear me?
Yes, yes, yes. You have to
Hello?
add on something to it?
Yeah, ma'am. In dehiscence facial nerve, if the nerve is bulging and the cholesteatoma is just the flags are just underneath the bulging facial nerve with the suprastructure intact. That is one of the scenario what I found a few days back. It was very difficult to remove those cholesteatoma just medial to the facial nerve, dehiscence facial nerve.
So
With intact.
what instrument do you use and what precaution do you take, and how can you
Yeah.
times come from
It was.
from the stapes side to lift it?
Yeah. We need to step it, but it's because of the instrument size of the instrument and the space in between the stapes and the facial nerve. If it is very minimal because of the bulging of the nerve, so it really gives trouble.
So what?
So in there, yeah.
How you
Yeah,
go about these cases?
Yeah, we can use some blunt or small peak-like thing along with the small cottonoid, but it takes a lot of time. We will have to be patient. Without patience, it's not possible.
Okay, so now this is
It
another
takes time, but
case. It is, as you have been telling, that it is stuck to the foot plate also. Cholesteatoma is sitting on the foot plate. So, and this is the bony posterior facial ridge. So, how you lift this this cholesteatoma sac of the foot plate? This is what I've been asking you.
okay. So again, it will take a lot of patience because maybe there are a lot of granulation and cholesteatoma are in between. So making a space would be a little bit difficult, but with the blunt dissectors and the plasters knife or flag knife, so we can do it gradually. But before going to that, we'll have to be very sure that whether the superstructure or the part of the stapes is there or not. If the a little bit of crura is also there and any lateral movement on the crura can be hazardous in this area, because it may cause the fracture of the foot plate and may cause hearing loss and all.
So, do you believe in
we'll have to be
using it more around by removing all the bone lateral to it, so as to make it very comfortable, like bony posterior canal wall or facial ridge, so to expose it nicely?
Yes.
So anterior attic, as I told you, it is many a times left. People don't, and this is the area where you tend to leave the cholesteatoma behind. So all this drilling around it should be done nicely, and every bit of it should be out. Now, already talked about it, Narayan sinus tympani and hypotympanum. What extra step you take to open it up nicely?
Is the question to me?
Yes.
Okay, nothing. As I already told you, you need to go as close to the facial nerve, both from lateral to medial, that's going over the vertical course of the facial, and even from the middle ear, you need to drill that ledge. The first picture that you're showing, you need to drill that ledge as close to the facial nerve as possible, and that opens up your sinus tympani. Many a time people get very worried in that area, but this is the same thing what I keep saying. People are always like, is there a facial? Is there a facial? Even in a case of stapes, we see the base of pyramid. So I keep telling them, drill till you see the base of the pyramid, and your facial nerve is not really going to, be a hindrance to your surgery. So go as close as possible to your facial nerve and make sure you've exposed that area widely, because that's the area you would leave behind cholesteatoma in case, if you leave behind epithelium, then that's going to be a case of recurrence.
And this is the same step as canalplasty. As we discussed in canalplasty, that part of the bone needs to be, and that is called, thinning of facial ridge or lowering of facial ridge. And if there is Dr. Piras, hello? Dr. Piras?
Yes. I'm here. I'm
exposed, lifting of cholesteatoma sac and clearing the granulation tissue, how you go about it? 2 things to share.
Well,
extra step you have in mind for lifting the cholesteatoma sac from these important areas?
Well, if the areas are not uncovered, I mean, if the sigmoid sinus is not uncovered as well as the dura, you can just dissect the skin and the matrix without so many problems. Eventually, you can use the bipolar. Eventually, you can use you can drill with a diamond drill. If the structure, I don't know if in these pictures, I don't know if the dura is
Both
uncovered.
they're exposed and cholesteatoma sac was
Well,
over it.
it depends how much of the dura is exposed, because when from the pre-op you already know that the dura is widely exposed. I prefer to go directly with a subtotal petrosectomy from the beginning, because in this way I can enlarge the approach, skeletonize completely the structure, and eventually even coagulate on the dura. Even if, for example, the sigmoid sinus is widely uncovered, instead of removing the cholesteatoma and obliterating with the soft tissue, I just prefer to close the cavity and keep the cavity safe, closing the eustachian tube as well.
Believe in repairing the defect and keeping it extended mesorectomy only?
It depends on how the defect is, how wide is the defect. But if the dura is extensively uncovered, and there is a chance of having CSF when you do the procedure and then you coagulate and so on, I prefer directly to start with a subtotal petrosectomy instead of doing a canal wall down and then obliterating or doing other things. If the defect is small, no problem. You can put a fascia, you can put a cartilage, you can put a muscle, and you cover the defect. It depends how wide is the defect.
So, okay, thank you. So now, important tips for ossiculoplasty. I'll ask whether you believe in doing single stage or second stage, autologous or allograft, special tips or pearls you have to share. Do you use spacers? Any difference in canal wall up and down? So, do you have something, Dr. Piras? We can start with you only, then I go to Narayan.
Well, I tell you that usually we postpone the reconstruction for two issues, because doing a second stage, obviously I can understand that probably in India you have much more patients than here, so sometimes doing a single stage is cost effective. In our institution we try to do a second stage, not always, but I mean in more than 50% of cases. In this way, you can understand. Obviously, if you do a canal wall down tympanoplasty, the risk of having a residual disease is very low, close to 0%. If you do a canal wall up, much more. But you can control both the cholesteatoma and do also ossiculoplasty as well. Usually, we use the incus of the patient, or if you don't have the incus, but this is a secret, we use another incus. We don't use we don't use titanium or plastic material, because the risk of extrusion is really high. We saw a lot of extrusions in the past, and so we prefer to use the patient own material, incus or bone or molded cartilage, but something that it's from the patient.
Okay, so you rarely use the allografts or synthetic implant, this thing?
I tell you, I'm quite sincere, never. I've never seen since I came in the group, because in the past they used a lot of allograft materials, but all of them, most of them extruded in time. So the results of the patient own incus or other patient incus is the same.
Okay.
It's much better. It's much better. I mean, it's much better, and you don't have any risk of extrusion.
So, Dr. Narayan, what do you have to say? Which cases you use second stage ossiculoplasty, and what material?
So like already Gianluca has said, and we all know, in India we tend to reconstruct the hearing at the first sitting itself. Okay, but every patient is told at the beginning that your reconstruction or ossiculoplasty may not really work to that great extent as you would really expect. The idea of doing an ossiculoplasty depends upon your status of the middle ear mucosa, etc. So if your middle ear mucosa is very healthy, you may get a resultant good hearing. But if your middle ear mucosa is unhealthy and you've done an ossiculoplasty, you may not get the desired result. That's one. Two, in our cases, we use incus if possible, the patient's own incus, not from outside, but we use the patient's own incus. And if I have any ossicle, that is even the malleus, for example, I would probably try to use one of the patient's own material. If I do not have either incus or malleus, the next possible thing I would use is a cartilage. The cartilage will not give you as good a hearing result as the bone itself. The bone gives you the best. The ossicle itself, patient's autoincus, would give you the beautiful hearing result. So you have to compromise a 5-10 decibel because of the flexibility of the cartilage. But all this is done at the first sitting itself. In this first sitting, once we do an ossiculoplasty, replace the graft and do a good meatoplasty, whatever we are doing it, we repeat the audiograms at 3 months and 6 months, and then take a call whether hearing is really good or whether it's not good. If it's not good, then we still have the option of going in and doing a second stage ossiculoplasty then and there. Okay, does that answer your question, Madhuri? I do not use titanium or any other materials because I do not believe in that. And I've, like Gianluca said, I have never used titanium for these cases where I think the extrusion rate would be pretty high.
So when what we do is usually single stage and they give very good results. It is not only because people cannot afford. It is that when we clear it, we do a good culture sensitivity, clear the infection, and we tend to place at least autologous grafts are done in one single stage only. And I use quite a few titanium graft, TORP also. And they do well if we do a coverage with a laterally placed cartilage or 2-point stabilization technique as in TOP. So they are giving good results. We ask our patients only. If we don't have, can we use? They say, okay, we get the consent and then we go ahead and do it. So Dr. Anjan, can you tell us? Do you
for me also, yeah. The same question, ma'am.
Hello?
Hello, can you hear me?
Yes, I can hear you.
Okay, ma'am. So for me also, we do here in a single stage in most of the cases. If sometimes very rarely, if I am not very sure, then I keep the patient for the second stage after 3 or 6 months. That is a very rare occasion. But in most of the cases, I do the reconstruction in the first stage. Mostly the reconstruction is done with the cartilages, and in very early diseases, if the malleus or incus is supposed to be not in contact with the cholesteatoma sac, in those situations, maybe I will remodel the incus or malleus head. But I prefer not to give those because there may be some osteitis or something like that. So I usually use cartilage, though with cartilage the results may be not as good as the hard bones or something, but cartilage gives you a long-lasting result.
So how frequently do you use spacers like silastic sheath?
Not really, very rarely. If there is a lot of granulations and I need to remove the middle ear mucosa, and sometimes then silastic sheath I use.
So, okay, thank you. Dr. Piras, do you use spacers frequently and do you tend to remove it or let it be there forever in life?
Sorry, I don't understand your question.
Spacer like, silastic sheath, or do you
Yeah. Usually, if the mucosa of the middle ear mucosa is very, very unhealthy, I use it. And usually I use almost always in canal wall up technique with posterior tympanotomy. So I put a silastic between the mastoid and the middle ear cleft. If I have to say a rate, I mean in 30% of cases I use them. Then I remove in the second stage.
Do you have any ever extrusion of that?
Yeah, it happened. I remember twice. Once in a canal wall down tympanoplasty, I have an extrusion of the silastic sheath. In another case, I have in a canal wall up where in the second stage I did not find any cholesteatoma, but due to the silastic, I have a persistent discharge outside the ear with a perforation and granulation on the tympanic membrane. So you may have cases where the patient does not tolerate the
Do you get gel films in your country?
No.
So, Narayan, do you have any idea? Do we get it in our
Madhuri, I would like to just go back onto the osteoplasty part once again, since that no, you have shown the correct picture, the allograph. Yeah, the silastic, the titanium implants which you showed, you were on that picture next.
Okay.
Yeah. So just a point to be said over here. You already, said that you're using this, and every whole of India and the country knows that you're a fantastic surgeon. You get fantastic results, and your book and everything. But I somehow would like to be very, very cautious about using any foreign material in a primary case. Okay, if this was a cholesteatoma, I don't ever use titanium. I do not object to people who believe in titanium using it in a second stage, but I would definitely not use it in the first stage. Okay, any of these materials. I would generally use incus and malleus. In fact, there's a question on the chat box. What about the integrity of the incus and malleus if there's a cholesteatoma involving it? So that's a very good question.
Yes.
Whenever there's a cholesteatoma around that incus, and you're taking off the incus, you remember when we are reshaping the incus, we are drilling off every aspect and reshaping the whole incus. So it's not only dissecting the cholesteatoma of the incus, we are reshaping the incus and drilling way beyond its outer layer. So then there is no chance of residual cholesteatoma.
If ever there is disease infestation with the disease.
Yeah. So if there is a very bad infestation with the disease, we even discard the incus. It's not necessary to use it. Okay.
Yes.
But if the incus is pretty much clear and you have it's a lenticular process, which is necros, for example, or the long process, we can use the incus body for reconstruction.
Of course, you agree to this principally, that the first and foremost is incus. Then we can use autologous cartilages. And if you feel in second stage or in first stage, if it is a clean case, then we can use the alloplast.
The first case will never be a clean case, Madhuri.
No, I mean,
like I said, you can use all these titanium and other stuffs on a second stage. But primary case, I think it should have to be, if you're leaving, just put a cartilage and leave it there and, go back for your second stage also.
Of course, because, they are costly, processes. So if it is in first stage, does not work, then unnecessarily you are on back foot. So you keep it for the second stage. Okay. So now coming to obliteration or reduction in size of mastoid cavity. So what materials, Dr. Anjan, you use for obliterating the size of mastoid cavity? I'll ask every one of you because this is an important question and people may be using different things. We must need to tell the audience. So Dr. Anjan, what are the layers? What is your usage? I will open up next what we use. First, you let me know what you use.
Yeah, my choice is only the soft tissue. I never use any other materials or synthetic materials. The soft tissue means the muscle, periosteum, and cartilage. So, from the very beginning, if I feel that the cavity should be big enough, then I make the incisions accordingly and prepare for the cavity obliteration from the very beginning of the surgery. And I don't use the glass material or any other bone dust.
This is such a deep cavity. How you reduce the size?
So with the I take some periods. If it's a very deep inside cavity, then I take the periosteum, fill the cavities, and over that I use the muscle.
Okay. So, Dr. Piras, do you have something different to tell?
No, I just use the musculoperiosteal flap. I tilt the musculoperiosteal flap inferiorly to obliterate the tip of the mastoid. Sometimes from the tip, I can obliterate from the tip till the level of the sinodural angle. Or sometimes if I have cells, you can use also cartilage, but I don't use heterologous material, just muscle and cartilage.
Okay, and Dr. Narayan?
Yeah, so I generally collect bone dust from the surface of the mastoid. That's the healthy cortex. You collect a lot of bone dust. Okay, that's, I think, one of the best materials because it's got osteoblastic activity. And at the end of it, so when we're doing the surgery right at the surface, you would collect it from the healthy. We never collect it from the unhealthy areas. And once you have that, you just keep it in, keep it in a cup. And at the end of the surgery, use that to sort of make your cavity very smooth. So the You can use it in the retrofacial cell area, sinodural angle, and so on and so forth. I also would not hesitate in using a bit of cartilage to obliterate the sinodural angle, the mastoid tip area, or any crevices. I would not hesitate to use a bit of cartilage as well. Muscles, fantastic material. I've used muscles, but somehow I'm not a fan of muscles to reconstruct. I know there's nothing scientific about it. It's just that sometimes you like a material or you don't like a material. Okay, it's just
Talking about free muscle graft or pedicled muscle rotation?
Pedicled. It has to be pedicled, never a free muscle graft. I have used pedicled muscle rotation flaps as you have described over there, but somehow I'm not very happy with the bulk. That's a soft wall reconstruction over which you put a little bit of, you put the graft and allow the epithelium to heal. It's a very good material used by a lot of people, scientifically proven. Personally, I'm not a fan of it.
Okay. So all of you have had different ways and you must be giving good results. Though for us, we find that they're too deep a cavity. We need to fill them up with cementing and like other things like cartilage graft, bone dust. Bone dust, it is very important to, if we are harvesting, we must harvest from an area totally away from the site of disease. It can be from the outer surface, lateral surface of the mastoid bone or squamous temporal bone, or from extra-aortic canal, but never close to the area of infection. So this is how we usually tend to do. So Dr. Piras, hello?
Yeah.
Dr. Piras, do you do something to obliterate the attic region to avoid the, retraction pocket to develop again?
I do what you are showing.
Okay.
Exactly what you are showing.
Keep a piece of
honestly, I don't use so much the bone, this bone dust, because there should be some risk of infection or swelling of the cavity. So I don't like so much the bone dust, but I usually put pieces of cartilage and the fascia over it. And you are showing what I usually do. So I can shift just this muscle, or eventually sometimes it's enough to tilt downwards the musculoperiosteal flap, and this allows you to obliterate the cavity as well. So honestly, I don't do something so different than you.
Okay, so muscle rotation inferiorly we can use postoral or sternocleido. Because this is a long muscle, we can use the width to split it in the middle to increase the length, and in the same way temporalis muscle can be rotated and fill the superior part. So all of us agree on this. Other ways are when we don't, in this case, like, sigmoid sinus was anteriorly placed. It was a tunnel-like thing, so I placed a cartilage there. So that way also you can keep reducing the, size of the cavity. So coming to meatoplasty, which is the most important part of the surgery, Dr. Narayan will agree. And we
Madhuri,
both...
just before this, I'd like to ask Gianluca one question.
Yes.
Okay,
Yeah.
to that previous area where you've shown the sinodural angle reconstruction. Yeah,
I don't agree with the last picture.
This one?
If you have this,
yeah,
I don't close this area. I keep this area open, and the way that the skin will cover all the cavity in this way, if there is some residual disease, it will be followed just with the otoscopy as a cholesteatoma pearl that you can remove in the office. But if you close this area and you have a cholesteatoma medial to this cartilage, you may face problems in the follow-up. So I usually, when there is such a contracted mastoid with such a narrow sinodural angle, I prefer not to obliterate.
Not to obliterate?
No, not to obliterate.
We cannot keep this. I would rather fill it with bone dust or more cartilages.
Madhuri,
Please tell
Madhuri,
me.
I think he's mistaken this picture of yours showing with that instrument showing the ventilation pathway. So it's not really, I think you need to specify that is obliteration of the whole area with cartilage. That instrument is a
standing cartilage rather than lying down cartilage.
Yeah, it has to be, the cartilage has to go right down on the mastoid cavity if you're going to be obliterating that whole thing. You cannot have that instrument below the cartilage.
Because it does not have cells there. So we have to obliterate it completely behind the cartilage.
So my question is, has anyone tried fat to obliterate a part of this cavity? And if someone has tried, Gianluca, just a thought.
Yes.
No, because
Have you used fat ever? And if not, why?
because if you have an open cavity, even if the ventilation is not perfect, but the fat is connected with the hair of the eustachian tube, so the fat with the hair can be reabsorbed. So
no, I'm not talking in this case. I'm not talking in this case. I'm just telling in general. Like you use muscle.
To reduce the depth of the cavity, he wants
Like
to
you use muscle.
With muscle, yes, I understood with fat.
Yeah, why not with fat?
No, fat, no, because it will be reabsorbed. Or the risk of this infection of this fat is higher than using the muscle. I prefer just muscle and eventually cartilage, but not fat. But
why people are averse to fat?
If the mastoid is like in this picture, is so contracted, there's no need on obliterating the cavity. You can leave the cavity as it is.
It will cause a
This one, you can leave the cavity as it is. The cavity will be very, very small at the end. You do metoplasty, the epithelialization will be perfect, and you can perfectly control this patient for his whole life.
Okay. So coming to metoplasty. So that is important.
But the issue of cavity problem will be there, no? In this situation, the wax debris will get collected, and this thing will have to be cleaned repeatedly. So
yes,
why don't you?
Posterior part of the cavity needs slight obliteration in a way to make a wide canal rather than a deep going cavity, which can cause, a collection of keratin and reforming of the cholesteatoma.
So Gianluca, the question about the fat was not related to this particular picture. I'm just throwing an idea for all of us to think. Okay, it just occurred to me, not that I have used fat. It just occurred to me, like we are using a pedicled muscle to obliterate the cavity. Why would we use fat? And ultimately, that's a non-ventilated area over which you're putting like a soft reconstruction. So instead of using muscle, use a piece of fat. We are using fat in all cavities to obliterate cavities. So why couldn't we use fat in the synovial angle and then put a, just as we use muscle? So in place of a pedicled muscle, is fat an option? That's the thought process which I just wanted to. I have not used it, but it did occur to me, possibly we can use it.
Okay.
We'll have to give another incision. Maybe that will be one of the issues, and we'll have to.
No, that's not a problem because fat is a structure which really, unless it's exposed to air, it was not going to be. We are using it for post-acoustic neuromyelitis.
Maybe because there is no vascularity for that, and fat will not.
Why do you require vascularity in that area? You just put a graft there, allow your cavity. That's a dead cavity behind your graft.
The rest of, I have seen in few cases that dust and cartilage pieces are well taken up and they become part of the obliterated cavity. And I have seen in few of the cases. I don't know how the fat is going to behave.
So but maybe Gianluca can ask Professor Sana and throw this idea.
No, he does not believe in obliteration. So if he does an open cavity, he never obliterates.
Yeah, that's fair enough.
Because he wants to check the cavity with the metoplasty. The advantage of not obliterating is that you have a big cavity and you can control directly in your office without any need of doing radiology. Because obviously, if you obliterate the cavity, well, the rate of cholesteatoma recurrence is very, very low, but it's not zero. So if you obliterate the whole cavity, you have to do something afterwards to control this cavity. And with the CT scan, you cannot control because you cannot understand unless you have a big cholesteatoma with erosion behind your obliteration. You can do an MRI with EWI sequences, but even in that situation, the risk of having false negative or false positive cases are quite not negligible. So Professor Sanna, if he does an open tympanoplasty, unless it's a very big cavity, it does not obliterate even with the muscle. So
yeah, so Gianluca, this is the exact reason. This is the exact reason why I'm not a fan of muscle, pedicled muscle.
Yeah.
So this is exactly why I told you. It's just, people are using it with fantastic results. But when I do a CT scan, I want to see a clean sigmoid. I want to see a clean dura. And, I don't, CT scan cannot be used as a surveillance measure then. Two, you have to use diffusion weighted and exactly the same thing as which you said.
Yeah, no, but the point is you obliterate, for example, before you told a very important thing. When you do a cavity, you should read sometimes also the cells at the level of the tip of the mastoid. So sometimes you may have a very, very big cellularity in that area that should be obliterated. So putting something to obliterate, for example, the tip of the mastoid, and you are sure that there is no cholesteatoma there, but just, for example, granulomas, it would be enough. But we are not fans on obliterating the whole cavity with muscle, just the tip, or eventually from the tip, from the sinoduralium, but not the whole cavity, because otherwise, if you have a cholesteatoma, it's a disaster.
The depth of the cavity is not
recognized.
obliterated with muscle.
Madhuri, this is the exact thought that occurred to me, and that's the reason I'm not a fan of closing it with muscle.
No, we don't obliterate. The lateral part of the cavity is covered with the fat.
I understand, but I never use muscle in the cavity. That's exactly the reason.
Great point to carry home. So now coming to myotoplasty. So Dr. Anjan, do you want to talk about it first?
Yes, actually the
it-
myotoplasty. Yes, the myotoplasty is just to look or for the cavity cleaning purpose. So it should be of adequate size. I don't do a very big myotoplasty, but most of the time I don't cut the concha. But metas, I definitely make I just ensure that I can look into the structures in the mastoid cavity, whatever it is.
So how many % cases do you require to do the conchal cartilage excision?
Not more than 10%.
In which cases do you have to do this?
If the cavity is very big, sometimes I am not, and there is some mastoid abscess cases, and those cases I did
Very extensive cases where even in spite of obliteration, we could not achieve the reduce the size of Okay. So, Dr. Narayan, myotoplasty, how do you go about it? And what special things to share with the audience?
Okay, so whenever you do a canal wall down, you need to have a more than adequate myotoplasty is what I would put it. People tend to do disfiguring.
Not wide, not less.
Yeah, disfiguring myotoplasty is something which is not a good thing in today's world. And that's where the concept of obliteration of cavities came in. Okay, so you don't want to have a very disfiguring, but you just have a more than adequate myotoplasty. And again, what I do is I cut the skin, maybe take out just a small rim of conchal cartilage. Normally don't need to do too much. In my cases, I rarely if I ever need to, remove that rim. Madhuri, can you show the conchal cartilage? So this is what I do. I just cut it and sort of reflect the two flaps on either side. Okay, superiorly and inferiorly. Yeah.
In between, we will start with this. So we don't give neototomy incision in the skin of the external canal anywhere. We lift it together so that we have a big tube of the skin available. And then, as you were telling, okay, go ahead.
This is exactly what I do. I don't need to do the conchal cartilage most often. I would say more than 99.99% of the times I've never had to resect a cartilage.
Yes.
Okay.
And then you reach up to the cartilage, conchal cartilage, then give 2 cuts and create 2 flaps, and then suture it to the side. Anything different, Dr. Piras, you do?
No, our technique is a little bit different than yours, but at the end, the result is the same. The principle is the same. We usually remove some millimeters of conchal cartilage just to avoid that after the cut, the cartilage will be exposed and so infected and so on. But usually we remove some millimeters of conchal cartilage.
Okay, in every case?
In every case, yeah. In every case.
Can it be avoided?
Sorry?
Can it be avoided? Because in our part, we have not been removing conchal cartilage, and it is wide enough, as you can see, a big finger can.
Oh, yeah. If the cavity is not so big, there is no need to remove the conchal cartilage. So, but
home message is try to protect and save the conchal cartilage till it is possible.
Madhuri made a very pertinent point, which says that you must not have an exposed conchal cartilage. The conchal cartilage gives rise to perichondritis, and then your whole myotoplasty begins to shrink. He made a very pertinent point over there.
Yes, you can create by cutting small slice of conchal cartilage. You rather can create a skin there and suture it back. So, good point. Don't keep the exposed cartilage rather than trim it. This is the point?
Yeah.
So, okay, these are a few, then we will go to specific situations. Dr. Vijay? These are the small size cavity after obliteration. We heal very well. There are no chance. They've been followed up for many years and we get good results even after obliteration if we have removed the disease well. So Dr. Vijay is there. So he will let us know when to stop because there are 8-10 questions more. Whenever he tells us, we'll stop there. So this question we can ask from Dr. Peras about congenital and pediatric cholesteatoma. What difference do you have for these two situations? Do you deal them in the same manner or you have different philosophy for these two situations, congenital and pediatric cholesteatoma?
Sometimes it's difficult to differentiate between these two entities because you may have a congenital that at the end is an acquired type. Well, in treating this disease, if we are quite sure that it's a congenital cholesteatoma, we always, unless it's a very huge cholesteatoma, we try to do a closed tympanoplasty. You see in children, usually the mastoid is so well pneumatized, so we do a classic closed tympanoplasty with posterior tympanotomy, acticotomy, and so on. So obviously the philosophy and also the management is a little bit different than an acquired cholesteatoma, because in acquired cholesteatoma the problem is this ventilation. So
you believe in doing closed tympanoplasty in congenital?
Yeah. In closed, because the pathophysiology is completely different from the acquired. So the chances of having a good cavity will be higher than if you do a closed tympanoplasty for an acquired cholesteatoma. So in children is the first stage, do a closed tympanoplasty. Usually staged, so first and second stage, but we try at the beginning with the closed technique.
So pediatric cholesteatoma, you go ahead and do the canal wall down mastectomy easily.
No, we do first a canal wall up, and then if cholesteatoma, if we have a recurrence, we do a canal wall down. But first we start with a canal wall up in almost all the cases. If there is a congenital cholesteatoma, if it's acquired and the cholesteatoma is contracted, it's a different story. But if it's a congenital in a child, canal wall up.
That leads me to a question that we in our country have changed the concepts now. Do you do CT scan in every case of cholesteatoma?
Yes.
I mean, every case, even if it has a small retraction pocket?
No, if it's a small retraction, no. But if it's a retraction that cannot be controlled and the patient has discharging ear, we do a CT scan.
Dr. Narayan, do you also do this lately?
Do what? CT scans?
Yes.
CT scan is done for every patient. When
Yes.
we do cholesteatoma, we do a CT scan for every patient. We don't take up a patient for cholesteatoma surgery without a scan. If it's a congenital cholesteatoma, I would sometimes back it up with an MR as well. But if it's a pediatric cholesteatoma, like Piras has already said, the acquired pediatric cholesteatomas, you would try to leave the canal wall up and try to eradicate the disease completely. That's at the pediatric cholesteatomas. The congenital cholesteatomas, like he's already described, could also be petrous apex cholesteatomas, and that requires a completely different sort of management protocol.
If it is a restricted disease, grading grade 1 to limited to
It depends completely upon the extent of the disease. I wouldn't hesitate to do a canal wall down if needed in a congenital cholesteatoma. But in a pediatric cholesteatoma, which is acquired, the right side one, I think I would stay with the canal wall up procedure for, and then of course this child has to be followed up.
Followed up for long. Anything new you have to add, Dr. Anjan? Hello?
No.
Same?
I think he's muted.
So okay, Dr. Anjan, can you go ahead and share with us if it is a case of post-oral fistula? Anything different from the rest what you do in routine cholesteatoma cases?
Oh, yeah, most of the time the pediatric cholesteatoma, what I find it here is they are in advanced stages. So in those situations, and I need to do the canal down procedure and ask them to come visit frequently. And whatever canal up procedure I did earlier, So in pediatric cases, I thought there were some recurrences. So nowadays, I tend to do mostly canal wall down in those advanced pediatric cholesteatoma cases.
I agree with Dr. Anjan because lately I have seen that, when you tend to leave this canal wall up, their tendency to, just beneath medial to this canal wall, we may be leaving the continuity of the disease is not there, which we have removed. So lately I tend to do canal wall down and do obliteration rather than doing a restricted drilling of the canal.
Madhuri, can I add on this? We are talking of canal wall up. Canal wall up doesn't mean we are not touching the posterior canal wall. Like I told you, it could be a lateral IBM technique with a reconstruction. Okay, so it doesn't mean that we are leaving the canal wall completely intact. We are always drilling the area lateral to your ossicles, making sure that the cholesteatoma is out and trying to leave the canal wall intact. Okay, that's because of the growth of the mastoid.
Absolutely. In cases of pediatric cholesteatoma, basically we don't do wide canal wall down. We just follow the disease by removing the lateral canatic wall and antrum, and then we tend to reconstruct the posterior canal most of the times. So anyway, Dr. Anjan, can you talk about postoral fistula? Anything different you do?
Yeah, postoral fistula. It's nothing different. It's the same way I do the surgery. Just take care of the skin of the postoral fistula area. We'll have to take out the skin, and rest of the things will be done same way.
So do you tend to wait for some time for getting the culture sensitivity done and getting rid of the excessive bacteria or some resistant?
I don't think so, ma'am. This kind of cases, whatever the culture sensitivity comes, we'll have to do the same procedure. If the skin is very bad, then I will have to wait for a few days with antibiotic. If the skin is otherwise in like this picture, so we can do it the same setting.
So Dr. Piras, anything different you have to tell?
No. I honestly agree with what you are showing, so nothing to add.
Okay, just be careful and remove the excessive friable skin around the fistula and then go ahead and do the outside. In these cases, we tend to do outside and follow the fistula rather than going from inside and make single cavity after doing the cortical mastectomy. Usually it remains the same. We just have to be careful to take care of the infection before going ahead and completing the surgery. So how to manage facial nerve and cholesteatoma? Dr. Narayan, do you find facial nerve involved? Do you find palsies, paresis, or different grading in cholesteatoma? What are the usually cause and extent of damage? How much do you find? Which segment is more common? And then we'll go to the management.
Okay,
First,
so generally speaking, facial nerves, when they're involved with cholesteatoma, it's very rare to find a palsy over there. Most of the times you find an erosion of the fallopian canal and you find the cholesteatoma, maybe adherent cholesteatoma matrix adherent to a dehiscent facial nerve. The dehiscences are more common in the tympanic segment because the bone there is very friable. Most of the cholesteatomas are the attic. So the region of the tympanic segment is the most commonly affected. I do not find cases of palsy except, very extensive cases, untreated, and for whatever reason, someone has done surgery, then you could probably find palsy. But otherwise, at the most, a facial weakness or just the cholesteatoma adherent without causing even facial paresis. Extent of damage, which segment mode? I've already answered that.
Dr. Piras,
anything?
No, I agree with Narayan. It's the same. I agree with Narayan.
So segment.
Okay. The tympanic portion is the weakest point, and if something happens, is because you damage the nerve. But sometimes you may face also some basic errors from when you do revisions. For example, people that are not able to load the facial ridge, so you may have also iatrogenic problems in the third portion. Looking at the details that you have shown, Madhuri, it's almost impossible to do this. So
okay,
I agree with Nayam.
So absolutely right. Because it does not erode the facial nerve directly, it just causes the ischemic changes or inflammatory changes of the exposed facial nerve, which is the cause of the facial palsy or paresis. Usually it is less than grade 5 or so in cases. Palsy is seen when it is associated with any granulation disease like tuberculosis, skull-base osteomyelitis, or extra this reduced immunity cases where you get extensive disease. There only we find palsy. Otherwise, it is most of the times paresis. So, Dr. Anjan, what special thing about facial nerve and cholesteatoma, how you manage it? Patient has come to us with a like this case. The CT scan is showing extensive cholesteatoma in cases causing the erosion of the sigmoid sinus plate, even tegment plate, and there is a fistula there, or rather, sorry, this disease affecting the vertical part of the facial nerve because there is no cover over that, and the patient is having grade 4 facial paresis. So, how do you go about it?
It's a very extensive cholesteatoma, so maybe it's going down to the vertical segment of the facial canal. So this is the area where if the cholesteatoma invades, they may cause palsy. And hopefully, in this case, after doing the adequate removal and decompression of the facial nerve, it may come out, because I don't believe that it's because of the it's only the ischemic sensitivity, because nerve cells is not yet damaged. And secondly, for the if there is a Levinson fistula, what I could see maybe, so fistula will have to be taken care, and facial nerve decompression will have to be done properly from the mastoid tip to the adeno. We'll have to decompress completely.
So, what do you mean by completely? Now I have two important
Complete up to, yeah, it should, the decompression should be from the tip of the mastoid, from the egg to the adeno. The whole facial nerve will have to be.
Agree with this, or you have some other idea how,
No,
how
well,
much decompression is?
I think that it is in this case that, well, I guess because there were no coronal cuts of your CT scan, but I guess that the facial palsy was due just by the compression of the cholesteatoma to the third portion of the facial nerve, the mastoid segment. I think if you decompress the facial nerve, removing the cholesteatoma in a case like this is enough. But usually when you have a paralysis more than grade 3, it means that the facial nerve could be interrupted in some ways. So, okay, you can decompress the facial nerve, but you have to be sure that the facial nerve is not interrupted in one of his portions. In this case, probably it was just the third portion involved. So it could be enough what you have done.
So, Dr. Narayan, and one question. How much do you decompress? He is absolutely right. We must check the continuity of the facial nerve. And decompression is actually limited to certain area where we find healthy nerve on both the sides. Do you believe in incising the sheath in these cases?
I never believe in incising the sheath of the facial nerve. Okay, for me, according to me, once the cholesteatoma is taken off from the facial nerve, this facial nerve is going to recover. As long as, like Gianluca said, there's no interruption of the facial nerve. So just lifting the cholesteatoma off is good enough, with maybe a millimeter or two on either side, just to make sure that there is no unhealthy tissue lying on the facial nerve. Just a couple of millimeters on either side of the exposed facial nerve. That's about all. But I don't think we need to decompress the whole segment.
Facial nerve is to be disturbed minimum if it is intact and has been compressed by this cholesteatoma. Just releasing it, and that much is good enough. And reconstructing this, and this he could recover to grade 1.
So Madhuri, I'm not a fan of incising the facial nerve, and I would prevent anyone from incising the.
No, I'm not just showing the normal.
Not you. I'm just passing on a message to everyone.
Yes, that is very important.
In an infected case, you really do not want to take off the epineurium of the nerve, because in an infected case, you're exposing this, the axons of the inner ear, of the facial nerve.
Barrier for infection.
Yeah. So it's got a very thick epineurial covering, which prevents infection from really, entering the nerve fibers itself. It's just the inflammation on the surface. Would you agree, Gianluca?
Yeah.
So not.
I agree with you.
Yes. So then coming to an iatrogenic facial nerve injury with neuroma, Many a times when we clear these cases, there is a big neuroma formed there. So, Dr. Piras, this is question for you. How you address a post-injury, post-hypergenic neuroma in cases of this facial?
It depends which is the facial nerve function. If the patient has a grade 3, Hausbrockman 3, so he can close the eye, probably I won't do nothing on this nerve. I will leave the neuroma and I will cover the cavity. If the patient has more than grade 3, so if there is a neuroma with a facial palsy without closure of the eye, probably there is an interruption of the nerve, so I will remove it and I will try a reconstruction with the graft. But if you do this, probably it's better to close the cavity and do a subtotal petrosectomy. We do not like to do a reconstruction with the graft, keeping an open tympanoplasty, a cavity which can be connected with the outside. But it depends on the pre-op facial function.
So, Dr. Narayan, what about you? Do you look for the grade of facial nerve or the condition of the involvement of the facial nerve by the neuroma? Do you
Sorry,
grading?
sorry. You have to consider that whatever you do, the patient will have at the end a grade 3. So keep in mind this.
But neuroma involving less than 1/3 of the this thing, thickness of the facial nerve, neuroma involving more than 50%, neuroma causing total fibrosis. There are 3-4 different kinds of neuromas. So how you take those cases one by one?
So Jian has actually put that, he's actually put that very well. What you're talking of 50% or more of the neuroma, of the facial nerve involved would obviously give you something higher than a grade 3. Like
but
he's
lesser can also give grade 6, grade 5.
Pardon?
Lesser involvement can also give grade 3.
Yeah, so you always are looking, that's what he just put it in different words, but I think you would look at the nerve quality itself. If you think it's a very big neuroma, like this is a nerve injury, iatrogenic facial nerve injury. If you think there's a bad facial nerve injury and you cannot see too many nerve fibers, then I wouldn't hesitate resecting it and putting a graft, like he said. But if the nerve injury is less than grade 3, or if the patient has landed up with a nerve injury and when you're operating the patient, you're seeing this patient with less than a grade 3, that means there is a fair bit of transmission across the nerve, and then probably you will not need to resect the ends of the nerve and put a graft. So I think what he said about grade 3 makes a lot of sense.
Okay, Dr. Anjan, while there is an exposed decompressed facial nerve in the surgical field, what precautions do you take when you do a ossiculoplasty and do the coverage of the facial nerve, exposed facial nerve?
Ossiculoplasty, if it touches the facial nerve also, it does not affect the facial integrity, or it does not cause any paresis. But if you directly press over the facial nerve, then it will definitely cause trouble. So if it is possible, we will do ossiculoplasty, or if just touching the nerve, I can go ahead with ossiculoplasty. Or if it is totally covering the footplate, so we'll have to abandon the ossiculoplasty procedure.
Okay. So, Dr. Piras, do you think you keep something to avoid fibrosis around the exposed facial nerve?
Well, in a case like this one, so where is a big not a big, but a neuroma, we do not perform ossiculoplasty, and we prefer to obliterate the cavity, not to keep a cavity open like in this case. So prevent fibrosis, I don't know. I don't know how to prevent fibrosis in a case like this. It depends from the pre-op facial function, for how long the patient has the paralysis. You cannot establish. You have to follow the clinical history of the case. But honestly, if I find a complete dehiscent facial nerve with a neuroma, the patient probably is a revision case. The patient has already a slight facial palsy. The chances of improving the hearing is not so high. I prefer to keep this facial nerve inside the cavity, close the cavity, remove all the cells, and put a fat in the cavity and do a closure of the external auditory canal. So do a subtotal petrosectomy.
Okay, so in our part of
It's
country,
rare that you have a case like this in a primary surgery. Usually these surgeries are revisions.
this is a revision case, definitely. And we could give improvement like this next case. There's a neuroma there. So the patient had grade 6 palsy. Grade 6 palsy doesn't mean that the nerve is already gone. Maybe the fibrosis is compressing the nerve there, or the neuroma affecting has led to the continuity of the fibers. So you see there is a neuroma there and continuity of the nerve around there. Just removing the fibrosis, we could get grade 1 in this case. So we usually we try to reconstruct the ear rather than do subtotal petrosectomy and pelvic closure, because in these cases we have been able to gain the hearing also, hearing and grade 1 facial recovery. So both things we tend to go beyond the neuroma on both the sides, try to see whether it is the fibrosis or sheath has gone into fibrosis or scarring, or the nerve itself. If the nerve is okay, only 20% or so, 30% of the fibers are involved in the neuroma, we still maintain the continuity and do, and this case we could get grade 1. So the message is we see for the facial nerve palsy, which could be 3 or more or 6, but the important thing is to see the anatomical and physiology of the facial nerve when we do the surgery. I think you agree to me?
Yes, yes.
So now, cholesteatoma with labyrinthine fistula. So before we go ahead, there are basically 3 types of this fistula. One is when this is the external layer is the periosteum, this is bone, this is endosteum, this is the perilymph, this is membranous labyrinth, and this is the endolymph. So when it is involving only the bony part of the covering of the labyrinth, it is type 1. Type 2 is when it goes beyond all the bone and disturbs, the perilymph, it pushes on the perilymph, type 2. Type 2B is when it disturbs the perilymph also, and type 3 is when it is entered the endolymph. So in cases of labyrinthine fistula, so Dr. Narayan, I can ask you, so how you decide that pre-operatively by investigation or during surgery you decide how to repair this fistula? And what special thing you can share with us?
Preoperatively, you will either look for SN loss or you look for the CT scan, which will determine the fistula, the size of the fistula, and their involvement of the labyrinth.
It will not be able to show the depth, okay? It will not be able to show the depth of the fistula, CT scan.
But you can make out the size of the fistula, okay?
Size.
That's part. So 2 investigations which will help me deciding whether there is a fistula is one is SN loss, and whatever is the hearing, you may have
Yes.
you may not have an SN loss also, but either which ways you need to look at the audiogram and the CT scan both, and then take a call on what you want to do to this fistula. 2, if you're talking about the management, when there is just a bony covering, the membranous labyrinth is not destroyed, I would just place a small piece of, say, perichondrium or periosteum over this layer and just leave it. I don't go and damage the endosteal or the endosteum or the membranous labyrinth itself. Okay. Whereas if it's a big fistula, then once the matrix is off, you're going to obliterate that with soft tissue, which is again a perichondrium or a periosteum. Just put it into, then pluck the fistula, so that it doesn't become a third window syndrome.
Okay.
Does that answer the question? Is that what you wanted?
Yes. Limited, I mean type 1 or type 2 or 3. When there is a SN loss, almost a dead ear, profound hearing loss, then you do something different, or it is the same for you?
Whom are you asking this?
So it is a dead ear. If it is a dead ear,
yeah,
you just push the things or just place a perichondrium over it. Periosteum or perichondrium.
So again, it doesn't matter whether it's if it's a dead ear, it doesn't matter. It's the membranous labyrinth, right? You really, whether you plug it or you're going to keep something on it, you're not going to regain the hearing. You just want to prevent a third window. So that's the reason you would make sure that if the bone is destroyed, like I said again, if your membranous labyrinth is intact, just keep some soft tissue over it and leave it alone. But otherwise, you plug it. If you're worried for any reason in a dead ear, just plug it so that there's no third window. And that prevents vertigo in the post-op period.
Dr. Piras, anything else you want to say?
If there is a dead ear, you go directly with the subtotal petrosectomy. No need of obliterating. You just go directly with the subtotal petrosectomy if you have a dead ear.
If
No
there is
need of taking the. So you can open the canal and remove the wall matrix. The patient has the hearing has gone, so you can do what you want.
So you do subtotal petrosectomy if there is a fistula with dead ear, but if it is not dead, then how you go about
Oh,
it?
if it's not dead, if the hearing is good and the fistula is small, you can remove the matrix of the cholesteatoma from the fistula, not using the suction on the fistula, and then you cover the fistula with a fascia or a piece of muscle. If the fistula is big, this is a big question. What we do usually is to leave the matrix on the fistula.
Okay.
Even if you have the risk of a third mobile syndrome, but you leave the matrix on the fistula.
Have you seen any cochlear fistula ever?
Yeah, sure.
So in
The
these,
problem of cochlear fistula is the risk of having inner ear damage is higher than a labyrinthine.
oh yes,
So sometimes the hearing has gone much before.
yes. So Dr. Anjan, if it is, this is another, yes, Dr. Anjan. This is another excessive cholesteatoma.
Hello,
Hello,
I can't hear you, ma'am. Tell me. Yes.
can you hear me?
Yes.
Okay. So extensive cholesteatoma with medial wall of the internal carotid artery is eroded. There is a cochlear fistula. There was a lateral semicircular canal fistula. Also, the facial nerve is also exposed. So,
Yeah.
what you're going to do about it?
Yes. About the previous cases in the lateral canal fistula, I wanted to add one point. So,
Okay.
if in the early disease, if there is a lateral canal fistula, we will try to avoid the canal down procedure, if possible at all, because canal down procedure with a cavity, the calorie effect becomes a troublesome issue for some patients, because if the cold air in the hill station areas that goes inside and it stimulates the labyrinth and gives the patients vertigo. If we give a cavity in the mustard with fistula. So mostly the fistula in those cases, I close in 2 layers. At least one layer should be a cartilage above. One periosteum or fascia and cartilage most of the time. Because cartilage I put because it prevent the calorie effect or
stabilize the
body pressure.
How do you stabilize the cartilage over the fistula?
No, ma'am. It's just when we obliterate the cavity, and this area should be covered with cartilage.
Okay. Okay. Even if it is endosteum or the bone is gone, then also you put a cartilage over it.
Yeah, if the bone is gone, and I will place one periosteum. Just make ensure that the cholesteatoma matrix is completely removed. Then I will place some periosteum, and over that I will put on cartilage, and whatever material I use to fill the cavity, that will do.
So what we do is usually put up, because bone is gone, so we put bone dust, and over that a bit of bone wax can be placed. That is for type 1 fistula. Now this is a very extensive disease, and here you can see through the thickness, the periosteum, bone and endosteum is gone, but the inside it, things seem to be normal. Membranous labyrinthine is absolutely fine, and he had hearing persisting. So in these cases, do you do 2-3 layers of the repair? How you go about it?
So in these cases, bone dust may be helpful, or you push some dust inside.
Dust
and
inside.
Yeah, it dust inside and block the canal.
Okay. So Dr. Piras, do you also do this, like, this is a deeper fistula, though hearing is maintained, and endolymph and membranous labyrinth is intact, how you go about it?
Was the hearing good in this case?
Good, not good, though there was conductive, there's no sensory neural loss.
No sensory. Well, I think it's a good option what you have shown. So it's something that has to be done as you did.
Piece of muscle, you can put inside and then put a bone dust and over that bone bags.
Yeah. The problem in such a big fistula is to be sure that you have not left any single cell of matrix inside. But anyway, if you are sure that the matrix has been removed completely, you can plug the canal like it is, and it's a good job.
Okay. So maybe 1 or 2 slides more. It is already too much time. So revision cases of cholesteatoma with meningoencephalocele. Okay. So you keep getting patients who have been operated somewhere else, and there's the patient comes with fogginess, heaviness in the ear, hearing loss, and many a time CSF leak also through ear. And CT will show the meningoencephalocele, and MRI will show the functioning or non-functioning of the meningoencephalocele. Dr. Narayan, can you talk about it when you get such a case? What precaution you take while doing the surgery and what special things you have to share?
Yeah, see, if there is, there are 2 things, Madhuri, in this. In fact, this and even the labyrinth and fistula, as Gianluca, just to clarify what he has also said about the subtotal petrosectomy, there are 2 reasons we do surgery of cholesteatoma. One is to eradicate the disease, and 2 is to preserve hearing. Okay. Yes. Now, in this case, in the labyrinthine fistula, if your labyrinthine fistula has caused a dead ear, then there is really no need to do a open cavity. You can just about, do a subtotal petrosectomy, or like you said, the one with the cochlear fistula, just do a subtotal petrosectomy, make sure the disease is out, and then come out. Now, in this case, if the meningoencephalus, if it's just a dural exposure, just a prolapse of the temporal lobe, I can actually give a support with a cartilage between the 2 edges of the bone and sort of replace this back. Okay, that is in case I'm thinking of an open cavity with a later hearing preservation, ossicoplasties, whatever. But if there is a meningoencephalocele completely obliterating the whole cavity, a huge meningoencephalocele, then in those cases, and of course, you just can't do anything, you can't push the temporal lobe back, then you would probably even think of cul-de-sac closure and some other secondary form of hearing. Okay. That's why I said that you have to decide on a case-to-case basis. There is no classical rule for this. If there is, again, just a small, like you see the second picture over here where your dura is just exposed and there's a very small prolapse, second picture. Okay, yeah, just a small prolapse.
This is the prolapse.
Yeah, this prolapse is fine.
It's reduced by bipolar cautery, and now this is a fascia over this. So that's
yeah, exactly. So if you can reduce it, if it's a very small herniation, and if you can reduce it, you would reduce it, and not only put fascia, put a piece of cartilage so that it doesn't prolapse further back into the cavity. Then you could do that. But if it's a necrosed bit of what do you say, temporal lobe, then you would probably have to resect that and then push the temporal lobe back, or once you resect it and there is a lot of CSF leak, close it and then do a cul-de-sac closure of the whole canal. That's what I would think of doing.
Absolutely right, Narayan. Dr. Piras, can you tell me how can we differentiate between a functional and non-functional part of the brain before surgery or during the surgery? How we decide that this needs to be excised or this needs to be shrunken back and reduced and put back into the cranial cavity?
Well, you understand, first you have to check properly the CT and MRI scans to see that if there is a brain inside the mastoid cavity, is non-functional brain. So you can cut and coagulate this brain because it's that brain, and you can realize before from the MRI. Sometimes you may have a dehiscent tegment, and you may have some granulations in the mastoid. So it seems from the MRI that it's like the brain in contact with the mastoid, and then you open the mastoid and there is no brain. So if you see before and you see the T2 sequence, the flare sequences on the MRI, you can realize if preoperatively there is some brain in the mastoid. If there is brain in the mastoid, it's non-functional brain, so you have to remove. And even if it's a little bit functional, you have to remove, because otherwise the risk of having an encephalitis is so high. So you have to remove this brain, coagulate, and almost always do a subtotal petrosectomy.
You always do subtotal petrosectomy in such cases?
Absolutely.
You're able to repair it. This is the post-surgery video for that. So if we have reduced it and repaired it, we can definitely
you are very lucky, because if the patient has an infection in the rhinopharynx, and if by chance it goes towards the middle ear cleft, he would have a meningitis. So it's much better to close this ear and to keep it safer and avoid any risks for the whole of his life of having a brain problem. But anyway, if there is just some dura in the cavity, so even if the defect is not so small, but it's just dura, you can reconstruct the tegment with the cartilage. So it's not. But if you have brain, I will be much stronger.
So have you done this middle cranial fossa approach for repairing?
Yeah, if the hearing is good and you want to preserve the hearing, and if the dehiscent part is not so wide, you can do a combined mastoid and mini craniotomy to reconstruct. Sometimes I tell you, if there are a meningocephalic herniation only in the mastoid part, so the middle ear cleft is not involved, you can just remove the meningocephalic herniation in the mastoid and obliterate the mastoid with fat and with some periosteum close to the ossicle. So sometimes you can do also this, but the mastoid should be
so you're talking about
obliterated with fat.
Telling that fat can be used in such cases for obliteration.
Yeah, preserving the middle ear cleft, but you have to be sure that there is no herniation in the middle ear cleft. If it's just posterior in the mastoid, you can obliterate the mastoid and it's enough that you can preserve the hearing. But if there is a huge encephalic herniation, you can do a combined middle fossa and mastoidectomy or direct subtotal petrosectomy.
So if the size of the defect is more, if it is small, we tend to put the cartilage bigger than the size of defect and push it, tuck it inside. And if it is, all these cases are when there is no CSF leak. So if it is a bigger than that, more than 2.5 centimeters, then we go ahead and do the for middle cranial fossa combined approach, transmastoid and middle cranial fossa approach. And through that, we take this squamous temporal bone and lift the brain and place it to repair the defect in the tech. So I think but it is true now, time is less. Do we talk about intracranial abscesses? So this case, you keep getting, Dr. Anjan, how frequently do you see cases with cholesteatoma with intracranial abscesses?
Not very frequently, but I saw few cases of abscesses. Those cases we did with along with the neurosurgeons, and neurosurgeons did the abscess, and after a few days I did the master surgery.
So you do it in 2 stages. First, your neurosurgeon does. You give a gap in between, and then you proceed and do the ear surgery. That is it. How you do?
Yeah. Whatever I did till now, it's like that only.
So what do you think that the neurosurgeon has achieved other than just draining the pus from above?
Draining the pus, because it's the situation of the neurology emergency. So mostly they get the patient and they do it immediately. And after doing the procedure, you cannot take up the patient in next 3 days. So patient is in ICU, I take the patient after 3 or 4 days and do the surgery. But mostly, if we can do in a combined approach in the same sitting, that would have been the best way of doing this surgery.
So, Dr. Narayan, what do you have to say about it?
Okay, good, interesting question. Madhuri, there are types of intracranial abscesses. One is in continuity with the mastoid, where you can follow a fistulous tract from the cholesteatoma going towards the temporal lobe or the cerebellum. If you find a continuous tract or granulation issue, then you can drain the abscess in the same sitting through a transmastoid route. If you have a remote abscess, far away from the area of surgery or far away from the cholesteatoma, then you would require a burr hole drain the abscess and do a concurrent mastectomy at the same sitting.
Yes, very good. So, Dr. Piras, how you go about it in your situation? You may not be getting such abscesses nowadays.
No, it's really rare. So I agree with Narayan. Sometimes, well, I have, once it happened to me, I had a case with a patient with a cholesteatoma that was operated with a canal wall down tympanoplasty. He had a huge cholesteatoma with a very pneumatized mastoid, and he developed an abscess after a week from the first surgery.
Okay.
And so we managed conservatively just with antibiotic therapy. It was okay. But it depends, as Narayan said, on what how is connected the abscess with the primary disease. So you can manage in the same sitting or eventually no. But usually we don't have any neurosurgeon that help us with this. If you have a abscess, we do in the same situation of the primary surgery. But fortunately, it's really, really rare.
So we keep getting, because at peripheral hospitals, we get these cases. So in our hospital, the principle is, if it has gone to the neurosurgeon, he will involve us and he will do the drainage from above. And the same sitting, I'll do the surgery of all the steps, draining, cleaning with betadine, hydrogen peroxide, and repairing in the same stage. And if it has come to me, I will inform my neurosurgeon, but then I will drain it through the transmastoid route only, because from above also by burr holing, they are just draining the abscess, they are not removing the walls. So here from mastoid side, we clear all the walls from the mastoid side, clear it and do the rest of the steps. So you can do a removal of cholesteatoma, locate the site, this is the site, and clear it, then remove the granulations and do all the steps after that. So this is, we give minimum time between the two surgeries. And as Dr. Narayan has said, that if it is not connected at the site of defect, then first the neurosurgeon will remove that abscess. Maybe it is seen, in one case, I had a case where there was an abscess in parietal lobe, whereas defect was in tegmen bone, and he was having nominal aphasia. So first neurosurgeon did it from above, but within a day, I took over and did the ear surgery forms. So if it is not connected, then two surgeries. If it is connected, then one surgery, or consecutively after the neurosurgeon. Okay. This was one case. ये बाहर निकाल, हाँ, आप कस के बंद कर बेटा, हाथ कस के बंद कर। आप कैसे हो? चक्कर तो नहीं आ रहे? Be corrected. Absolutely fine. सब बिल्कुल ठीक है? खाना? So the conclusion is, thank you very much for all of you to be there, because it needed a lot of patience and detailing. So conclusion for today's panel is, know the anatomy, have the concept about the spread of disease. Canalplasty and meatoplasty are important steps of cavityless cholesteatoma surgery. Open up the hidden areas and clear every bit of disease. Don't scoop out the cholesteatoma from under the bony ledges. Final cavity should be one single circular cavity, where roof of middle ear aligns with the roof of mastoid cavity, and floor of middle ear and extra-aortic canal should be aligning with the floor of mastoid cavity. Conductive hearing loss can be improved substantially by performing a good ossiculoplasty. And last, cholesteatoma disease is curable. Thank you very much. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you very much. Thank you very much, the entire team who has done extreme steps to organize this webinar. Thank you, Madhuri ma'am, and all the panelists, and also the faculty, international faculty of SAFLA. Thank you so much. And next month also we are going to have difficult scenarios in voice disorders on 28th July, which will be moderated by Dr. Nupur Nerurkar. Please join on 28th July. Thank you so much.
Thank you. Bye-bye.
Thank you.
Bye.
Good.
Bye-bye. Thank you. Thank you.
Thank you, everyone.